All right, we're going to get started. So, good afternoon and welcome to the OREF Midwestern Region Resident Research Symposium. I'm Jennifer Wolf, the chair of orthopedics here at the University of Chicago. My co-host is Rex Hayden. Rex, please wave, who's on our faculty as well. You're going to hear more about this from Lee Millman, who is going to talk about OREF. But OREF is a really special organization, and research in orthopedics is a really special thing because research supports innovation in our field. And if you ask a big question or a small question, if you ask why we do a surgery or use a certain medicine or whether we can do something better, these are all valuable questions. And so by being here, I want to congratulate all of you who are presenting and all of you who are here supporting them because you've contributed to our field. I want to do a few introductions and then Lee will speak. So our judges today are John Moriatis from the University of Mississippi, Ilya Salim from University of Michigan, Alfonso Mejia from University of Illinois Chicago, who I hope is on his way. maybe he's limping along outside. I hear parking is difficult. Mary Kate Erdman from the University of Chicago, and Tessa Balich from the University of Chicago. So we're very pleased to welcome you all here today. So I will now call a plea. Thank you.
Good afternoon, everyone. It is a true honor to be here at the University of Chicago for the Midwest OREF Resident Research Symposium. This is an absolutely phenomenal venue. The view is out of this world, and I hope that Mike and his team get a shot of this when we're during the presentations, but we're very, very happy to be here. OREF's been putting on these Resident Research Symposium for over 20 years, 23-ish years? And they've always been a big hit and a signature event for OREF. This is the third of 6 symposia that we're doing for 2025. We've already been to the University of Miami, University of Pittsburgh. We have one coming up next week at University of California, San Francisco, and then one following that about a week and a half later or so at the Hospital for Special Surgery in New York. Our last symposium will be our national symposium, so the top 3 winners from each of the regional symposia go on to the national competition. That will be on November 12th, and it'll be a virtual symposium. So there are prizes that come along with your great presentations today. I have a couple things that I need to do for housekeeping. There's going to be 3 sections of presenters today. Each section, your talk is in there. Somebody will put that up on the laptop, and you can find your presentation and click on that to put it in presenter mode. I'm going to do that when I start my presentation. So you'll get to see a boomer struggling with technology here, and hopefully I don't become a meme as a result of that. Probably will. After you're done with your presentation, if you could please sit at this table over here. When we're done with each section, you'll be asked to come to the front of the room, and the judges will be asking questions. And if there's time, we'll open it up for others in the audience to ask questions. All of the presenters have received evaluation sheets as well as a sheet to judge your fellow presenters. The person that has the highest score of your fellow presenters will receive also an award. It's called the Presenter's Choice Award, and that comes along with the cash prize. As I mentioned before, the top 3 presenters today, in addition to a cash prize, will be invited to compete in the national competition. The winner of the national competition gets an all-expense paid trip to the Academy meeting next March in 2026 in New Orleans, Louisiana. A good time will be had by all, for sure. After each session, please give your, and this particularly for the judges, please give your summary sheets to Carmen, who will be floating around the room collecting those. This symposium is being recorded, so whenever you do talk, we'll have mics that will be passing around. Please use your mic to talk or to respond to the questions that you have there. Now, with that, let me see if I can pull up my presentation. Getting there. Oh, I think that deserves, didn't embarrass myself too much. So what I wanted to do is to kind of go first through thanking those that have made this possible. Obviously, Dr. Wolf and Dr. Hayden as the co-host for this meeting. Thank you very much for your involvement. This is not an easy task for us to pull all of you together and for you to take the time. We really, really appreciate not only you, but the University of Chicago for hosting this symposium. Our keynote speaker today is Dr. Josh Jacobs. You can see his credentials here as well as his titles, but among one of his most important titles is that he is the current president of OREF, and he'll be sharing his experiences and knowledge and research as well as OREF later today. Dr. Wolf already introduced our judges. Thank you very much for the time that you've taken to get here. Dr. Moriatis is receiving the prize for the person coming the furthest. So we'll get you an extra cup of coffee for that. We could, this symposia and our program would not be possible without the support of our industry sponsors. As you can see here, it's Johnson & Johnson MedTech, Zimmer Biomet, and Smith & Nephew, and we cannot thank our sponsors enough. And a heartfelt gratitude also goes out to the Hark family, who has been very supportive of OREF, as well as all of our educational programs, and particularly the Midwest Symposia. They not only are supporting this, but they're the ones that are sponsoring the cash prizes for all the symposia this year. So it's great that they're doing them. So I'm going to talk a little bit about who and what OREF is, because it seems like just about everybody in orthopedics knows or has heard about OREF, but not as many people know what we do and exactly who we are. We are in our 70th year. This organization was founded in 1955, I'm sorry, by orthopedic surgeons for orthopedic surgeons to address the lack of clinical research in orthopedics and to spur that. And I think we've been pretty good at holding true to that mission for the entire time. We've awarded in the past year approximately $1.2 million in grants, and we have an active portfolio currently of about $7 million of grants that we are managing, which is approximately about 100 grants that we're doing. One of the most important aspects of our mission always has been to feed the pipeline of new investigators, to encourage those people that want to make research a part of their clinical career, to find them, to present them and provide them with the opportunity to have that avenue to actually do that and to forward their research. One of the other, and I think one of the things we're the most proud of, is that OREF is a unifier in orthopedics. We work with approximately 60 MSK-related organizations. And as you can see from this slide, if you look at the pie chart, we are funding, our research covers all aspects of MSK. We are, when it comes to body part, we're agnostic. It's wherever the priorities are, donors giving us money that for a particular area of orthopedics, but we feel it's important that we are supporting and funding research in all aspects of MSK. We're also very active in funding research, resident education. It's approximately $900,000 that we've funded over the last 5 years, and we're also raised money for other orthopedic associations. As you can see here, in the last 5 years, we've raised approximately $4 million that we've shared with our 60 organizations that we collaborate with. In total, it's been almost $20 million that we've donated, that have been donated to us, that we've used for the mission of OREF over the last 5 years. We are primarily funded by those of you in the room. Over 70% of our donations come from orthopedic surgeons, because they feel that this is an important aspect of the field, and we are the only organization that is doing what it is that we do. As you can see here, these are the departments, bless you. These are the departments that have been supporting OREF, and that number grows every year, and we're hoping that a few of the departments that are represented here today might join this distinguished group of institutions that contribute on an annual basis and support the mission of OREF. Now, so none of this really means anything unless we can document and talk about the impact that we've had. And we believe that our impact is among the best of any foundation, research foundation, that is in the U.S. I've worked for a number of other nonprofits over the years after I got out of the orthopedic industry, and almost all of them have been involved in some aspect of research. And I've been served on boards that were associations of other associations as well. And I do not know of any organizations whose impact, the return on investment for donations are of the same level as OREF. OREF presents a very unique opportunity to the orthopedic surgeons in terms of providing their generosity to us, because what we do on a daily basis, what we fund, actually has a strong return on investment that goes back to the orthopedic community and improves the outcomes of your patients. What we've documented in terms of our ability to take the initial seed money that we give for our funding, it has a very, very high impact, a very strong reputation on going on to get greater federal funding. All in all, if you get a grant from OREF, you have about a 20% chance of getting a federal funding, which is, again, I'm not aware of any organization that comes close to that. Our highest awarded grant, our Career Development Award, about 50% of those recipients go on to receive major NIH funding. And overall, we've seen that it's about a 500% increase in funding from that initial funding is what we've been able to provide. Our resident grant recipients also have a very high percentage that go on to be selected for academic careers, about 64% of those. And this is very relevant to today, that those residents that get the awards at the symposia also have a very high percentage that go on to be selected and to do their careers in an academic center. This is a very, very small sampling of some of the more significant grants that we have funded in their infancy that went on to change clinical practice. Doctors Tom Skolkoll, Heckman, and Greenwald a few years ago looked at our almost 5,000 grants and then selected the top 250 that really went on to have a major impact on changing clinical practice. And as I said, this is a very, very small example of some of those studies that we funded initially that are now being used or implemented in your day-to-day practice. So I want to switch gears here a little bit to talk about our current situation in the U.S. All of you here know that the burden of disease in musculoskeletal, for all intents and purposes, dominates healthcare. It is by far the largest burden of disease in all of healthcare. It represents about almost $1 trillion annually. It's about 5% of our GDP, just in MSK. But with that high burden of disease that MSK has, it's among the very lowest of areas that are funded by our federal government. As bad as that has been historically, and as much of a disconnect as that has been historically, since January, it's gotten much, much worse. And all of us know that. We see it in the headlines, we feel it in our department, and it is currently where we are. This is an example of where our funding is compared to other major disease conditions. As you can see, it's extremely low. So what we're doing at OREF now, using our collaboration, using the fact that we represent all specialty areas, is that we're working with everybody that's in the orthopedic community to come together to look at different ways that we can close that funding gap that is virtually non-existent from the federal government at this point. We know how to do major grants. We know how to do multi-centered grants. We know that we can do a big grant for relatively low money compared to the federal government. So we are reaching out to everybody, to all the specialty associations and others, to work with us to design these more impactful, more significant research that will make a difference going forward. And we've divided our research portfolio basically into 3 different sections, looking at pain and all the aspects of that, emerging technologies, as well as biologics as the priorities going forward in the research community. No other organization does what we do. As you can see here, this is these are all the major areas that we focus on, and that's obviously improving clinical practice, meeting the needs of early career seed funding to get people started in their careers, filling the pipeline of new clinicians, driving innovation, as well as funding all subspecialties in MSK, and nobody does what it is that we do. And what we're seeing is that our mission now is much, much more important than it ever has been because of this disparity in the burden of disease compared to the funding levels, as well as what's been happening recently on the federal level. So we ask to please support us so that we can continue to do the work that all of you will benefit from. As for residents, we have an opportunity there for you to also to give, and you don't have to give a lot. We have a program with one of the industry partners that we have where they'll match whatever you give. So even if you give $25, that would become a $50 donation. So please consider that when you're looking at giving to us. So part of my talk today is to ask you to please support this organization. We're solely committed to funding research in all subspecialties that improves clinical practice and patient outcomes. So with that, good luck today. Have a great day and enjoy yourselves. And thank you for your attention and thank you for being here. Let me pull this section up.
While you switch, Dr. Hayden and I are going to share moderating. So I'm going to moderate this first and second session. For those presenting, you have 5 minutes. We're starting a little late. We are not going to shorten your time. We'll shorten questions if we have to. But please keep in mind that 5-minute warning. And when you see me hold up a thing that says 1-minute warning, I'll write it. Please pay attention to it because it's respectful to all your fellow speakers. Please don't go over time. So we'll begin without, and I won't stand up for the rest of these, by calling up Dr. Day, who will speak to us on fibular non-union.
Hello, everyone. Apologize, Dr. Day was actually not able to make it here today, so he's my co-resident. I'm Drew Carter. I'm a PGY4 at the University of Mississippi Medical Center, Orthopedic Department. So yes, we're going to be talking about fibular shaft non-unions in the setting of tibial shaft fractures. Let's see, will it do it? Okay, here we go. So just to let you know, I'm a resident, so I have no financial disclosures or conflicts of interest with information. I'm presenting on behalf of Dr. Day and the research team that took place, that put this together. So the objectives of this project were to determine the rate of fibular non-union in tibial shaft fractures that were treated with intramedullary nail fixation. Also to identify the factors associated with fibular non-union and evaluate the impact of fixation method on non-union rate when the fibula was fixed. So the clinical problem, up to 85% of tibial fractures have an associated fibula fracture, whether it be distal, mid, or proximal fibula. It's very scarce in literature about fibula non-union rates, but so they can vary from 0 to 29%, and there's limited data on the factors that affect it. So this was a retrospective study over a 9-year period at the University of Mississippi Medical Center, which is a level 1 trauma center. Roughly 400 patients were involved. So all tibias treated with intramedullary nailing were included and required a minimum of 3-month follow-up. We based categorizing a non-union based on the modified Russ score of less than 8, less than or equal to. The primary finding was roughly a fifth of the fibular non-union rate with the tibial shaft fractures. Average age of 40 years, about 2 to 1 male to female, and almost a little over half were open. Some significant associations with this were 25% of the non-unions were distal third, which was significant with a p-value of 0.03, and as well as fixation method, which was absolute stability with plate and screw fixation, had a higher risk of non-union. This just goes to show the percentages of the non-unions which were fixed by plate fixation, 29%, versus flexible nailing or no fixation. So this showed that there was a significant increased risk with absolute stability with plate fixation. Some of the takeaways from the project was there's about a 21% fibular non-union rate, which was higher than many had reported already with tibial shaft fractures. Distal third fractures had a higher risk of going on to non-union. And out of the fixation methods, if you were to decide on fixing the fibula, a flexible intramedullary nail or screw proved to have the lower of the risks when it came to non-union. And going back to refer to another paper, that if there were a fibular non-union being seen, that it did have a high correlation with tibial non-union to follow. So that's it. Yep.
Great job keeping us on time. Okay, we'll call up Dr. Todd, who will talk to us about femoral neck fracture rates following ballistic fractures of the femoral shaft.
Alrighty, perfect. Well, first off, I'd like to thank everybody for allowing me the opportunity to present today. I am Matt Todd. I'm a PGY4 at Franciscan Health Olympia Fields, and this is our paper on ipsilateral femoral neck fracture rates following ballistic fractures of the femoral shaft. I'd like to thank ultimately the team. It truly was a team effort in getting some of this data together. Clayton Welsh, Michael McGraw, Colin Cantrell, and our PI, Bennett Butler, out of Northwestern. So this has always been a hot topic in the literature, making sure we're not missing an ipsilateral femoral neck with a femoral shaft fracture. I think diving through the literature, a lot of our kind of workup in the management of this injury started with Tornetta. This was back in 2013. assessing the femoral neck fracture rates with an ipsilateral femoral shaft. And a lot of the current management we use is dedicated to his work, the idea of using a CT 2mm cut, getting our AP lateral radiographs, both pre-op, intra-op, and post-operatively with intraoperative fluoro to make sure we're not missing this injury. Kind of moving down the line, Dr. O'Toole took this a step further, assessing basically with our plain radiographs, positive predictive value in terms of whether there's a ipsilateral femoral neck fracture prior to our CT rendering for these injuries. This kind of deep dives all the way down back to Arhewoh, all the way back in 1996, and it's kind of been very dedicated to this blunt injury. So kind of taking a step back further, femoral neck fractures with an ipsilateral femoral shaft has been shown to occur at a rate of 1 to 9%, but these are still missed pretty commonly. 20 to 50% has been cited of this missed injury on presentation. This now falls back to the Tornetta protocol of taking our pre-intra post-operative radiographs, our CT scan to assess whether there's this ipsilateral femoral neck fracture and delay in diagnosis, whether this is missed at the post-operative follow-up or even just getting out of the OR. So now understanding this is more of really been focused on a blunt mechanism. And we kind of wanted to see if there was an association between ipsilateral femoral neck with ballistic injuries itself. And just kind of understanding a little bit more about the background of blunt injury mechanisms. These are usually done through a longitudinal force, transmitted up through the femur, through a flexed and abducted hip. A lot of times we could think about people being in car accidents, but ballistics, do they really behave the same way? Ballistic injury is not just the injury of the bullet striking the bone, but the ipsilateral or the indirect forces that are generated by the bullet's energy. Thinking back to our medical school days and how basically the physics behind this, as the bullet enters the soft tissue, there's not just the direct injury, but this temporary cavity that's formed. It's been shown to be about 12.5% of the bullet diameter, and it creates not just soft tissue trauma, but create indirect energy through the bone as well. So with this understanding, we were hypothesizing that through either direct extension of the comminution from the fracture itself or the creation of a wide temporary cavity, that these ballistic fractures behave very similarly to the femoral shaft and femoral neck in blunt mechanisms. So in terms of our methodology, we performed a retrospective review of ballistic diaphyseal femur fractures treated at a single level 1 trauma center from 2015 to 2023. Our inclusion criteria were age greater than 18, operatively treated femur fractures, known ballistic mechanism. Some exclusion criteria, again, age greater than 18, so we took out our pediatric patients, patients that were treated without surgery, fractures with primary zone of comminution that extended within the intertroch, femoral neck, supracondylar, distal femur regions. And then we scanned through all these patients' imaging using x-rays, CT scans, and then classified them according to the AO, OTA classification, 32A, B, and C. As you can see here, predominantly these were ballistic injuries, fair amount of comminution, 32C injuries. So to really get an understanding of what this injury was, we tried to stratify it a little bit further here. We measured the distance in millimeters from the most medial point of the lesser trochanter down to the most proximal extent of the direct fracture comminution AP radiographs. When the primary shaft fracture had extension above the lesser trochanter, we used negative values, and when we had available CT imaging, we followed a similar methodology. In terms of our results, our patient population was 77 patients. Again, we talked about it was 94% being AO 32C injuries. CT imaging was available in 86% of our patients. The average distance from the lesser troch to the most proximal extent of our fracture comminution was seen to be about 63 millimeters. And 2 of these patients, we'll come back on this later, so 2.6% of the femoral shaft fractures had a direct extension into the femoral neck. These were respectively 21 and 33 millimeters. As you can see on CT imaging, the uninterrupted fracture line for the primary zone of comminution was that direct extension of the fracture itself. So falling back on all these papers that kind of led to where we were now, Tornetta talking about his protocol, O'Toole assessing sensitivity of detecting femoral neck incidents using just plain radiographs. We also falled back on some of the study limitations that were available, small sample size, being 77 patients, retrospective in nature, and some confounders. One particular we found was that more than half the patients in the series had fixation across the femoral neck with the use of recon intramedullary nails. So our results kind of fall back into the literature, with just 2.6% of the patients being affected in terms of a low rate of femoral neck involvement. But I think more in particular what was important was there was no femoral neck fractures that occurred independent of the site of primary femoral shaft comminution. This was uncovered on both intraop and postoperative x-rays, and there was no new findings found from the CT imaging prior to the OR. So what does this tell us overall? That these injuries behave very similar to blunt mechanisms, but due to a different kind of mechanism of injury. And I think more importantly, it also tells us that in terms of future direction, whether CT imaging is really going to be useful in terms of identifying these injuries just based on outside of the preoperative x-rays, and whether these injuries, especially if they're more mid-shaft, truly have a similar rate of occurrence. Thank you, guys.
Thank you. We'll call up Dr. Montoya, who will speak to us about novel telemedicine system for management of statewide hand trauma in Arkansas.
I'm looking for a presenter view. I don't see it up here. Does anybody see it? Huh? Okay, let's see. Oh, I see, yeah, okay, perfect, thanks. Good afternoon, everyone, and thank you for being here. My name is Katherine Montoya. I'm a PGY4 orthopedic surgery resident at the University of Arkansas. And today we will review the key findings of a database analysis of encounters collected through the Arkansas Hand Trauma Telemedicine Program, or the AHTTP. I have no disclosures and want to acknowledge that the telemedicine program this study investigates is supported by state funding from a tobacco excise tax, but no additional funding was obtained for purposes of this research. Managing hand trauma across any state, but especially in rural states, is logistically complex. Points of organizational challenge include triage, treatment, communication between treating facilities, and arranging continued care, just to name a few. In Arkansas, as in many states, there are a paucity of fellowship-trained hand surgeons, with few centers equipped to deal with complex trauma. Thus, a geographic mismatch exists between patient need and treatment capacity. In Arkansas, 72.6% in the year 2013 was the percentage of hand traumas that were processed through the trauma system that were transferred via EMS to a higher level of care, so 3/4. In 2014, the HTTP was established by a group of 7 fellowship-trained hand surgeons in partnership with the Department of Health's centralized trauma management system. The goal was to improve access to hand trauma care and decrease unnecessary utilization of EMS resources statewide. The Broadband Technology Opportunities Program grant was used to provide every ED in the state with audiovisual technology to facilitate telehealth encounters. So this is how it works. A hand trauma presents to their local ED. They contact a centralized triage entity called the Arkansas Trauma Communication Center, who then connects them with an on-call hand surgeon remotely 24/7, 365. The consulting surgeon will remotely evaluate the patient clinically and then together with relevant imaging, and then either recommend temporization with associated follow-up plan or transfer. The objective then of our study was to analyze the database of encounters processed through this system to evaluate its effectiveness as described by interfacility transfer rate and thus EMS utilization, cost savings, and overall access to expert care for hand trauma. We directly analyzed data collected from all encounters from 2015 onward, and the data from the 2 preceding years were obtained from a prior publication. This graph details the total number of consults for hand trauma processed through the AHTTP. The blue dot represents the year prior to the program's inception, and you can see how tremendously system utilization has grown since the establishment of this program, with almost 1,000 consults in 2023 alone. Altogether, this gives us a grand total of 7,260 consults from 2014 to 2023. Here we have a map which depicts the geographic origin of AHTTP consults analyzed in this data set. They originate from nearly every county in our state. And here's the map you just saw juxtaposed with a map of where each star represents one board-certified hand surgeon in Arkansas. This disparity again highlights the true logistical challenge that it is to manage hand trauma in a rural state and how this program is bringing expert care to those that otherwise would have limited access to it. This figure depicts hand trauma transfer rate via ground EMS. You can see the marked before and after improvement associated with the establishment of the hand telemedicine program, and thereafter still statistically significant improvements in ground EMS transfer rate have been observed. Here you see a statistically significant downward trend in hand trauma transfers made via air ambulance in Arkansas since the establishment of the telemedicine program. So what's the bottom line? Assuming an otherwise unchanged rate of transfer in the absence of the hand telemedicine program, we estimate that about 2,519 ground transfers for hand trauma have been prevented by the program. Using the same assumptions, we estimate that about 156 air ambulance transfers have been prevented. And importantly, this translates to an estimated cost savings of about $6 million. This is based on the CMS fee schedule for Arkansas, which is probably a gross underestimation. In conclusion, the Arkansas Hand Trauma Telemedicine Program has successfully improved access to expert care for hand trauma across the state of Arkansas. It has facilitated a significant decrease in EMS transfer rate, which correlates to an estimated cost savings of about $6 million. And while, of course, we are excited about those deliverables, we're also proud that observed improvements herein represent increased availability of EMS services for other patients who need them. So as we look to the future, we'll be implementing the American Society for Surgery of the Hand's recently published guidelines for hand surgery consultation and transfer to empower local emergency departments to help ease the burden of the growing number of consults. And we anticipate that this addresses what we have noticed anecdotally to be an increasingly indiscriminate use of the system. In all, the HTTP has proven an elegant solution to a complex problem. We hope to take what we've learned from our first decade with this program to streamline management of trauma across our state and perhaps even serve as a model for especially rural states to tackle this difficult demand in emergency surgical care. Thank you guys, and I'll take any questions.
Questions are ready. Thank you. Questions are at the end.
Oh, sorry. Oh, they're all the way at the end. Got it.
We're calling up next Dr. Burke to speak to us about nicotine dependence as a risk factor for complications after flexor tendon repair. Okay. Then we'll move on. Dr. Jan, mid-carpal stability persists with less than 33% distal scaphoid resection, 3D computational analysis.
Okay, good afternoon, everyone. Thank you for the opportunity to share our work today. My name is Kyleen Jan. I'm a third-year resident at Rush. This is mid-carpal stability persists with less than 33% distal scaphoid resection, a 3D computational analysis. So when it comes to wrist arthritis, total wrist fusion is still often used as a salvage or last resort operation, very good at eliminating pain, but of course eliminating motion. So partial fusions therefore aim to give patients some type of balance between motion and stability in addition to pain resolution when properly indicated. One type of partial fusion is a RSL or a radioscapholunate fusion. So this is indicated in patients who have an arthritic joint between the proximal row and the radius, but a preserved mid-carpal joint. And there are numerous fixation methods to achieve this as seen on the right. However, there's no such thing as free lunch, right? So early outcomes of RSL fusions reported that if the entire scaphoid was left intact, the mid-carpal motion would overload the SCT and the capitolunate joints, decrease flexion and radial deviation, actually impinge there, and accelerate mid-carpal arthritis. So the procedure therefore evolved. So surgeons started excising the distal scaphoid to unlock the mid-carpal joint, providing improved motion, durability, pain relief. But how much do you cut? 10%, 50%? Nobody really knows, and it's left more to feel rather than evidence. So that's what we wanted to investigate in our project. So there have been biomechanical and clinical studies that recommend less than 25% distal scaphoid resection. There are also studies that describe cutting the scaphoid even more proximally at the waist. So there's really no quantifiable basis for these thresholds that surgeons are using. So our research question was, how much distal scaphoid can you excise in an arsal fusion without compromising mid-carpal articular support? To do this, we performed a retrospective study using 3D models of the wrist segmented by available CT scans in patients with non-trauma-related etiologies. We then simulated different excision levels from 0 to 66%, as seen here. And then finally, we calculated and compared the overlap between the scaphoid and capitate based on each excision level. Overall, we had 22 wrist scans that met our inclusion criteria and were segmented to create the 3D models. On average, they were middle-aged, 50% female, with the dominant hand being scanned in 55% of cases. So this graph here shows that compared to the intact condition, the 25 and the 33% distal scaphoid excision models preserved really good scaphoid capitate overlap, maintaining 99 and 96% area respectively, as we see here in the yellow. And there was no significant difference in these areas. However, this really dropped to 74% overlap when you cut out half the scaphoid, and then further to 43% when you cut out 2/3 of the scaphoid. And these reductions were statistically significant compared to the previous 3 states, as well as with each other. Here's just another way to visualize that data based on the scaphoid capitate overlap. So on top, we have the intact 25 and 33% excision states, where nearly all of the overlap is well preserved. And then here on the bottom, you can see quite a significant visual drop in the area once we reach the 50 and 66% overlap, excision states. And then finally, if we project each data point of each of the 22 models on this graph, we can see and recognize 33% as an inflection point where that surface area overlap starts to drop. So in conclusion, we found that up to 33% of the distal scaphoid can be excised without compromising mid-carpal stability, as represented in our project by scaphoid capitate overlap in our 3D models. But beyond this threshold, further excision might result in significant reduction in articular support, suggesting a biomechanical limit. So of course, future research could benefit by investigating how this actually plays out clinically. How does the overlap change in positions other than wrist neutral? There are also other questions we can ask about how scaphoid excision relates to different fixation techniques or adjuncts, such as triquetrum excision, as you see here on the bottom right. But overall, we hope that our findings provide quantitative guidance for surgeons seeking to optimize both stability and motion in RSL fusions to provide a durable outcome for patients with wrist arthritis moving forward. Thanks for your time.
Thank you. And we'll round out this session going to foot and ankle with Dr. Cho, who's going to speak about patient-reported functional outcomes following Charcot foot reconstruction.
Alrighty, thank you everyone for having me. My name is Elizabeth Cho. I'm a 5th-year resident at Loyola. So Charcot foot arthropathy is a devastating complication of diabetes and can lead to progressive deformity, ulceration, infection, and amputation. Surgical reconstruction aims to restore a stable plantigrade foot, but outcomes, especially from the patient's perspective, are not well defined. Our study objectives were to evaluate changes in patient-reported outcomes up to 1 year after reconstruction and to determine what clinical and radiographic variables, if any, might influence those outcomes. This was a retrospective cohort study. We included adults with diabetes-associated Charcot foot arthropathy who underwent reconstruction over a 2-year period. Patient-reported outcome measures were collected at preoperative 6-month and 12-month intervals and included the following 4 measures, including the PROMIS Global Health, PROMIS Physical Function, the PROMIS Pain Interference, and the Foot and Ankle Disability Index. In total, we had 27 patients who completed surveys at all 3 time points. The median age of our cohort was 59 with a median BMI of 36, reflecting the typical obese diabetic Charcot population. Majority of our patients were treated with external fixation, and about a quarter of our patients required reoperation. Complications in this cohort included a persistent wound in 33%, infection in 15%, non-union in 7%, and notably no amputations. At final follow-up, over half were able to return to regular shoes, while about a third of our patients required braces or orthotics. Looking at our outcomes, we saw a statistically significant improvement in PROMIS pain interference scores at 6 months compared to baseline. However, this improvement was not sustained at 12 months. Other domains, including the global physical health, the physical function, and the foot and ankle disability index, trended positively but did not reach statistical significance, as you could see from our p-values in this table. And interestingly, the global mental health scores trended negatively, but was also not statistically significant. On item-level analysis of the Foot and Ankle Disability Index, patients reported meaningful improvements in several pain items and daily activities, including sleeping, personal care, and recreational activities. However, only pain improvements persisted through 12 months, particularly pain at rest and pain with activity, as well as general pain. On subgroup analysis, we found that external fixation was associated with improved outcomes on the global health, foot and ankle disability index, and pain interference measures. We found that infection strongly predicted worse outcomes across all measures, and that deformity location also mattered. We found that midfoot disease was associated with higher pain interference scores, whereas tibio-talar involvement was associated with worse physical function scores compared to the rest of the cohort. Limitations of this study include the retrospective design and the small cohort size, which may limit our statistical power. Furthermore, it's a single institution study, which may limit the external validity of our findings. Single institution with 2 surgeons. And there also may be a ceiling effect in PROMIS scores among this population, chronically debilitated patients with diabetes, as well as several other comorbidities. And that may potentially limit the sensitivity of these instruments to detect clinically relevant changes. In conclusion, Charcot reconstruction can lead to meaningful short-term improvements in pain and function. However, outcomes remain heavily influenced by infection status and deformity location, which underscores the need for meticulous preoperative optimization, individualized surgical planning, and realistic patient expectations. Thank you.
We're going to shorten our questions to 5 minutes, just in the effort to stay on time. So I'll open this up to the judges to ask their questions. Oh, you're standing up? Okay. Gotcha. Okay. Try to shut your thing here.
Is it on? Okay, good. Nice job, everybody. For Dr. Todd, a question. We see lots of ballistic femur fractures here at the University of Chicago, as I know you did in your cohort. How do your findings change the recommendations for how we approach these patients clinically? Should everyone still be getting a CT scan to look for femoral neck fractures?
So that's a thing that was definitely brought up amongst the group. I guess the idea is a lot of these patients are coming in through trauma patients already, so they're going to be getting most often their dedicated AP pelvis with a CT abdomen pelvis, depending on the nature of the injury itself. It would be interesting to deep dive into our kind of patient population, see which patients did not get CT abdomen pelvis and whether a CT or dedicated CT pelvis is really going to change. The literature or our data is kind of pointing towards, unless it's a proximal femur fracture, say in the subtroch region, whether there is going to be a true incidence of ipsilateral femoral neck. or just essentially a extension of the comminution itself. So I think more literature has to go into that, but I think it is pointing towards that direction.
My questions are Dr. Carter. So the rate of fibular non-union, can you talk a little bit about the clinical relevance of your finding?
So from what I gathered from it was that is more of if you start to see what may be concerning for a fibula non-union, you may want to look more closely and more frequent follow-up of the tibia as well, because that kind of leads towards, from what they found, tibial non-union as well. And then based on also the fixation method for the fibula, to lean towards more flexible intramedullary device rather than a plate and screw fixation. It's more recommended.
I had a question for Dr. Cho. Excellent presentation. With regards to patient-reported outcomes for these patients, I mean, you had 27 patients, it looks like, in your analysis, and then you followed them for a year, and then you also had a subgroup analysis. Was your study adequately powered? Did you look at that, and what are next steps?
Yeah, that's certainly a good question. We are hoping to expand the cohort with another year follow-up or additional patients to add to the cohort. We did not perform a power analysis to see whether the study was adequately powered, but we did use a biostatistician who helped break down the cohort into what she thought would make the most sense. But we certainly recognize that as a limitation.
My question's for Dr. Montoya. Great presentation. Really sort of resonated. Being in Mississippi is very similar to Arkansas in terms of the geographic spread and the lack of providers in some of the rural areas. My question is, has this been looked at to expand to different parts of the body, foot and ankle, for example? And why do you think this has worked so well for hand surgery?
So in short, we have not looked at it for any other specific like body system or orthopedic subspecialty, but I think for hand it works really well because especially in hand, a picture's worth 1,000 words, and you can just kind of take a quick clinical image or a quick video and send it, or be able to see it in real time and kind of know what it needs with an x-ray, or at least be able to quickly triage, like, no, you do not need to put this poke hole open metacarpal fracture in an EMS and send it across the state, and be able to quickly kind of help to not waste that resource. And I think also hand, there's a big room for improvement with hand because hand kind of sometimes exists in its own little silo, and there's often like different call pools for hand versus general orthopedics or any other orthopedic subspecialty. And so I think there's just a lot of room for improvement. And so I think there was sort of bang for your buck, for lack of a better term, for hand and not wasting those resources.
1 minute warning.
Dr. Jan, because we can't leave you out from questions. So how do you know that the amount of overlap, right, that you found that inflection point of 33% is clinically significant?
We don't. It's a radiographic study, right? So I think a good study to move forward would be to kind of simulate these different levels in a prospective study, considering hopefully that people don't devastatingly fail. But like I said, like people don't operate in risk neutral, right? And so we need to kind of evaluate these overlaps and how patients feel at these different levels and also in different positions. I think the beauty of something like an RSL is that it preserves that mid-carpal joint, which allows patients to have that arc of motion and that dart thrower's motion. So radial deviation, wrist extension, and an ulnar deviation and wrist flexion, which is a very human motion. And so it'd be interesting to see how that overlap plays clinically and how patients feel at those extremes of motion.
Have you thought about looking retrospectively?
Mm-hmm. Yes, I think we would need a larger sample size of patients that make meaningful conclusions from that type of project, though.
Great opportunity for a multi-center study.
Took the words right out of my mouth, yes. Okay, thank you all. We will go on to the next session. Thank you. All right, our next speaker So Dr. Farouk is not here, so we're going to go on to Dr. Nakken, who's going to speak to us on optimizing contact pressures of the posterior heel during lower extremity immobilization, biomechanical study.
Hello, my name is Erik Nakken, and the title of my project is Optimizing Contact Pressures of the Posterior Heel During Lower Extremity Immobilization, a Biomechanical Study. Our team has no disclosures. Funding for this study was provided by the University of Michigan and a grant from the AOFAS. So this is our problem today, posterior heel pressure injury. I hope you ate lunch already. On the left, we have a healthy teenage female after a Liz Frank OREF who had a stage 3 pressure ulcer from a splint. On the right, we have a quadriplegic patient after bilateral Achilles lengthening with bilateral stage 1 pressure injury from a cam boot. So today we're going to be discussing how to reduce contact pressure of the posterior heel while in a splint or a cam boot to hopefully reduce the incidence of these pressure injuries. But how big is this problem? Well, pressure injuries cost over $11 billion annually in the United States and are the second highest healthcare claim. Splint-induced pressure injury is the second most common plastic surgery referral, and the incidence of complications related to prefabricated pneumatic braces, such as cam boots, increased the most of all immobilization devices during a prior 5-year study period. So a few things we know. We know that dermal arteriolar capillaries collapse with pressure greater than 32 millimeters of mercury, and remember this important threshold. Ulcer formation can occur after only 2 to 6 hours of contact pressure, and obviously patients are in a splint or a cam boot much longer than this time. And there are multiple risk factors for pressure injury listed here on the right, and those we commonly see include neuropathy and nerve blocks. So this led to our research questions. Can simple changes in splinting technique reduce posterior heel contact pressure? And this pertains to variables such as padding thickness, type, or heel position, such as floating the heel. And can this also be applied to cam boots? And it's important as no studies yet exist on these topics. So here are our methods. We tested 20 legs in 10 patients without foot or ankle injury. A pressure transducer was applied over the posterior heel, and they were splinted in the usual fashion. Pressure was measured initially with no padding in the splint, and this served as each patient's baseline. And then from there, we added 2 different brands of padding. Witex, which is a thinner padding, you may refer to it as Webrel, or Specialist, which is a thicker padding. And we tested the contact pressure with 2, 4, 6, 8, and 10 layers of padding, both with the heel resting down and the heel floating. And then we also tested the heel down and heel floating in a cam boot. Pressure measurements were compared to this 32 millimeter mercury threshold, the pressure of dermal arteriolar capillary collapse. So let's first look at our results in a splint. Floating the heel, as seen on the right in B, rather than resting it down in A, was the most important tested variable in our study. We'll see why in the next slide. The average contact pressure of the heel was above the important threshold of 32 millimeters of mercury when the heel was resting down, regardless of padding thickness applied. This average decreased below 32 millimeters of mercury when floating the heel for 8 and 10 layers of padding. On this graph, we see the effect of padding brand. On the top 2 lines are heel down, and the bottom 2 lines are heel floating. The top line in each graph is the Witex, and the bottom in each group is the Specialist. 6, 8, and 10 layers of Specialist padding were at or below 32, while 8 and 10 layers of Witex padding were at or below 32. One additional finding, a few times during the study, there was a sudden spike in pressure measured that did not follow the general pressure trend. After removal of the extremity from the splint, it could be seen that the padding in the posterior heel had bunched up like in the image on the right, and this caused this spike in pressure. And this bunch padding here on the graph is seen in the left in blue, and the evenly applied padding after a repeat measurement is on the right in magenta. Bunched undercast padding can increase the peak contact pressure by about 2 to 6-fold with an average of 3 times the contact pressure. Now onto our cam boot findings. Here's a graph of our overall data. We have a big outlier in subject 11, so let's look at it without that. The blue dash bars on the left are pressure with the heel down, on the right with heel floating. Note that all legs with the heel resting down are above 32. Let's see, can we go? There we go. And so the heel down, 0% of, whoa, hold on. Sorry, guys. Stealing my thunder. It's not going, I'm sorry. I know, now it's going. It's not following the arrows. When I clicked a few times and it'll glitch. Okay, there we go. So with the heel down, no legs were under the 32 millimeter mercury threshold, and the average pressure was 85. With the heel floating, 55% were under the threshold. And 55% sounds good, but let's remember in school, maybe, you already saw it, that gets an F. Okay, so here are the conclusions and keys to victory. If you don't remember anything, remember to float the heel, both in a cam boot and a splint. Float the heel, float the heel, float the heel. We recommend 8 to 10 layers of padding with either brand of padding. And remember that education is important on floating the heel and these other factors that we talked about, and beware of bunch padding when applying a splint. And then more on cam boots. We don't recommend sleeping or prolonged use without frequent skin checks, especially in a patient with sensory deficits. Thanks, and go blue.
Thank you. All right, our next speaker is Mark Plantz, talking about preclinical safety and efficacy assessment of a novel 3D printed hydroxyapatite demineralized bone matrix composite scaffold using a rodent posterolateral fusion model.
Thank you. Good afternoon. My name is Mark Plantz. I'll be presenting our research project entitled Preclinical Safety and Efficacy of a Novel 3D Printed Scaffold. I'd like to thank the OREF and then University of Chicago for hosting us today. So pseudoarthrosis remains a challenging complication, particularly after lumbar spinal fusion. BMP2 is known to reduce this risk, but it's expensive, also yields a host inflammatory response that can cause complications. Prior research has shown that DBM and HA-based materials have shown some efficacy as bone graft extenders in the lumbar spine, but they're not often used as standalone bone graft substitutes. So the purpose of this study was to design and assess the efficacy of a 3D printed copolymer of HA and DBM as a standalone bone graft substitute in a preclinical rodent lumbar fusion model. So our material briefly was a 3D printed matrix with a PLGA backbone and then 70% by volume HA-DBM particles. So the HA-DBM matrix was essentially as 3 parts of HA to every 1 part of DBM by volume, and that was based on some prior research that we had done. So our animal model was a rat, a L4-5 posterolateral fusion model, which had been previously validated. And essentially we compared the HA-DBM group to various control groups, including BMP2, HA, PLGA, and the absorbable collagen sponge. So our main outcome measures, we looked at fusion scoring, biomechanical testing, qPCR gene expression, Western blotting histology, and then basically lumbar MRI to look at the surgical site edema. And we'll discuss each of these in more details. So fusion scoring was determined by basically manually explanting the spines and looking for bridging bone on either side. So that's rated on a scale of 0 to 2. So a score of 0 indicates no bridging bone, a score of 1 is unilateral, and then a score of 2 is bilateral bridging bone. And we also looked at radiographs, but we didn't use those to calculate the fusion scores. So we did biomechanical testing as well for 10 fusion samples in each group, in addition to 4 non-operated controls. So basically the samples were loaded with 5 cycles of flexion extension. We measured the segmental range of motion, and then the mean stiffness was calculated for each specimen. And then we did some mechanistic assessment for the 4 groups listed here at various time points. So 2 days, 1 week, 2 weeks, and then 8 weeks post-op. We looked at each fusion bed and each animal separately. So the left side was used for PCR and Western blotting, and then the right side was used for histology. And then lastly, we looked at the MRI basically to assess the host inflammatory response or the local soft tissue edema from each implant. So we looked at that at 2 days, 5 days, 10 days, and then 8 weeks post-op. So we normalized the T2 images, basically used the software to compare the volume of edema after a certain threshold between each group at different time points. Statistical analysis, we used ANOVA and post hoc testing for continuous variables, and then a chi-squared Fisher's exact test for categorical variables. This is some of the data. This is the mean fusion scores for the HADBM and the BMP2 groups. So the fusion score was 1.5 in the HADBM group, and then 2.0 for the BMP2 specimens. But looking at fusion rate, which again would be at least unilateral fusion, it was 93% in the HADBM group, compared to 100% in the BMP group. This is some of the biomechanical data. So the range of motion of both HADBM and BMP specimens was lower than the non-operative control group. And then the second plot shows the mean stiffness, which again was higher in the HADBM and BMP2 groups. And then as expected, basically BMP had the lowest range of motion and greatest stiffness out of all the groups. Really briefly, this is a heat map here. It shows the relative gene expression levels for different osteogenic markers. So the HADBM group had a 2 to 5-fold increase in several different markers shown here. I think the important point is that it's significantly greater than the HA group alone. And then lastly, this is the Western blot results, just showing protein expression levels, and again, they're elevated for the HADBM group compared to the control groups. And then lastly, this is the MRI data, which showed that the HADBM group had a lower volumes of soft tissue edema compared to the BMP2 group at both 2 and 5 days post-operatively, and it was essentially comparable to the negative control, which is the collagen sponge. So in conclusion, fusion rates were similar between our two groups. Both HADBM and BMP resulted in greater stiffness and reduced range of motion compared to controls, although BMP had a stiffer fusion bed. HADBM had significantly less surgical site edema than BMP2. Here's our references. I'd like to thank all of our co-authors, and thank you for your time.
Thank you. Our next speaker is Dr. Arhewoh, speaking on anticoagulation increases complications without reducing DVT or PE in lumbar decompression surgery, a propensity match study with prospective outcomes. And hopefully I didn't murder your name today.
Let me see. Okay. Hi, everyone. My name is Remy. I'm a PGY4 resident at the University of Michigan. I'm here to present my study on lumbar anticoagulation used in lumbar spine surgery and its effects on complications in patients. All right, so I have no relevant disclosures. All right, some quick background information. The use of anticoagulation in spine surgery is pretty controversial. This is due to the competing risks of thromboembolic events or the reduction of those events versus surgical complications. And while spine surgery is considered as a whole, we also know that there are anatomical location and instrumentation distinct risk profiles, which may also interact with the use of anticoagulation. There has been prior studies that have been done to kind of explore this topic, but they've been limited by small sample sizes, retrospective designs, a lack of clarity regarding the reasons behind anticoagulation, which are kind of three big ones. At our institution, we have the neurosurgery and orthopedic spine departments, and they have very different views on the use of anticoagulation, with one group deciding to use it routinely and the other group deciding not to. In addition, over the last decade, we have contributed to a prospectively collected statewide database, allowing us to kind of track our patients' outcomes with more granularity that you can find in some other studies. Here's some quick words I will be using. All right, so as I mentioned, we had this multi-center prospectively collected database, which we queried for all the patients at our institution over the past decade. We also reviewed the charts, so we didn't want to just assume that these patients got DVT or did not get DVT prophylaxis. So we went through each patient's chart to the time of surgery to make sure that they did adhere to their department's prescribing patterns. Finally, we excluded any patient that had a history of a DVT or that had any hypercoagulable conditions. After we did all this, we had about 3,000 patients, of which we then propensity matched to try to balance their baseline characteristics. Our primary outcomes: 1, rates of DVT-PE, the rates of wound complication, the rates of hematoma requiring reoperation. Then we also created 2 composite measures: neuro complications and any complications. For tests, we used t-test and chi-square test as needed for categorical or continuous variables. This is just showing quickly that pre-matching, our cohorts were pretty different, but after matching, they were pretty similar across multiple metrics. Our matched cohorts had a mean age of about 63. They were 89% white and 58% male. We also matched by procedure type so that did not influence our final results. So what were our results? There was no significant difference between the rates of DVT-PE or hematoma across the entire group. But when we looked at other complications, it's a much, much different story. CSF leaks, new weaknesses, just a wide range of neuro complications, GI complications, length of stay, and discharge to not home locations were all increased significantly in the group that got AC. Weirdly enough, return to OR within 90 days was higher within the non-anticoagulation group. But as I mentioned, instrumentation does create a very different, distinct risk profile. So we did some subgroup analysis. Looking at the patients that had some kind of lumbar fusion done, we see that there was no differences between both groups across a wide range of complications. We still saw that increased return to OR within 90 days, and so we kind of looked a bit into that, and this was due to some increased infection cases in patients that did not undergo anticoagulation. But how about lumbar decompression? Yeah, we suddenly see a very similar risk profile. We know that correlation is not causation, so we did some regression analysis to see how much anticoagulation was playing a role in this. What we find is time to discharge and prior spine surgery are major drivers of complication, even looking at other specific complications. How about for just decompression alone? Yeah, we see that DVT, PE, and hematoma, we could not find any significant predictors, but we see, again, prior spine surgery keeps coming up. And finally, by the time we get to neuro complications, anticoagulation becomes a major driver of new neuro complications in patients that underwent lumbar decompression. In conclusion, routine anticoagulation use is associated with increased wound and neuro complications among patients. This is particularly pronounced in isolated lumbar decompression, so your lamis, your microdiscs. There's no reduction in DVT or PE risk. If you take anything home, selectively utilize anticoagulation in patients, maybe favor them just for your high-risk patients, and be extra careful with this, especially when you're performing an isolated lumbar decompression. These are my co-authors, and thank you.
Thank you. We'll call up Dr. Maheshwer, who is going to speak to us about predictors of ACL ligament re-injury and return to sport in adolescent athletes, increased risk in younger age and earlier time to return to sport.
Thank you, everyone. My name is Bhargavi Maheshwer. I'm a resident at Case Western Reserve in Cleveland, and today I'll be talking about the predictors of ACL re-injury and return to sport in adolescent athletes. So ACL injuries are increasing in incidence in adolescent athletes specifically. And this is largely due to earlier participation in sports, as well as increased injury awareness. However, this can have quite a devastating impact on future athlete performance, as up to 14% of these young patients with ACL injuries do not return to sport. And this is ultimately important to look into because the demographics and variables associated with ACL injuries in this population are largely unknown, and the risk for secondary ACL injury is often greatest in the early return to sport period. And there's an overall lack of literature investigating the type of sport played, as well as the mechanism of injury on primary and recurrent ACL injuries, as well as the surgical management amongst high school athletes. So the purpose of our study was to characterize the epidemiologic trends of ACL injuries and secondary tear rates in high school athletes, as well as determine variables associated with sustaining a secondary ACL injury, which we defined as a contralateral ACL tear or a primary ACL graft failure. So we looked at a prospective database over 5 years and patients having greater than 2 years of follow-up, and we looked at various demographic variables, including age, physeal status, sex, race, BMI, as well as the school grade. And we also looked at sports and surgical variables, such as primary sport, mechanism of injury, graft type, the time to return to sport, the number of physical therapy visits, as well as the duration of follow-up. So we had patients between the age range of 13 to 18 who sustained an ACL injury, and 431 of these patients comprised our cohort that participated in high school sporting activities. And 344 patients did not sustain a secondary ACL injury, and we had 87 patients that did sustain a secondary ACL injury that was further broken down into graft failure, as well as contralateral ACL injuries. And looking at the demographics of the sports played by these athletes, we saw that football, basketball, and soccer comprised over 50% of our patient cohort. And looking at our baseline results, we saw that patients with a secondary ACL injury were significantly younger in age. We saw that patients who sustained a primary graft failure had overall less physical therapy visits, and there was a time range of 14 months from their initial ACL surgery to their primary graft failure. And patients with a contralateral ACL injury, there was a 19-month gap between their initial surgery to tearing their contralateral ACL. And then looking at graft failure and contralateral ACL injury groups specifically, we saw that there was no significant differences in sex, BMI, and time to return to sport between these two subgroups. And then when performing multivariate regression analyses, we saw that the age at the time of primary ACL reconstruction, as well as the time to return to sport, were associated with an increased rate of primary ACL graft failure. And we also saw that the age at the time of primary ACL reconstruction was associated with an increased rate of contralateral ACL injuries. And we also found that as age at the time of primary ACL reconstruction increased by 1 year, the rate of secondary ACL injuries decreased by 27%. And a 1-month delay in return to sport was also associated with the significant decreased rate of ACL injuries secondary by 13%. So thus a younger age at the time of primary ACL reconstruction and a shorter time to return to sport were associated with an increased rate of secondary ACL injuries. Some limitations for our study was that this is a single institution study, so there are limitations in the generalizability. There are differences in level of play that we did not do subgroup analyses for, such as varsity, junior varsity, and freshman sports, as well as the documentation of physical therapy that can vary when some patients go to outside physical therapy facilities not within our university hospital system or do at-home therapy. So in conclusion, younger age and decreased time to return to sport following an index ACL injury were significantly associated with sustaining a secondary ACL injury in the high school athlete population. And this is ultimately very important in the in-office clinical setting when providers are having discussions with patients and their families in terms of counseling these young athletes to allow for adequate rehabilitation and the time to return to sport. And next steps would be to perform further studies to optimize the development of specific return to sport protocols and timelines applicable for these unique athletes. These are my references. Thank you.
Thank you. And next we'll call up Dr. Timmermann, who's going to speak about Achilles tendon rupture injuries in Major League Soccer, 10-year analysis of injury rate and return to play.
Sorry, one moment. Okay. So my name is Annie Timmermann. I'm from the University of Chicago, and I'm presenting the Achilles tendon rupture study in Major League Soccer, a 10-year analysis of injury rate and return to play. I'd also like to acknowledge the PI for this study, Dr. Brian Forsyth from Rush. So Achilles tendon ruptures are common among athletes, especially in sports such as soccer that require explosive movements like sprinting, cutting, and jumping. These injuries can have a huge impact on the mobility and performance of players, which poses long-term challenges for an athlete's career. While there's an extensive base of research on Achilles tendon injuries among various sports, data on return to play among Major League Soccer in particular is limited, especially as soccer is of growing interest in the United States. So in terms of methods for our study, we queried the MLS injury surveillance database for Achilles tendon ruptures between 2010 and 2021, identifying 185 players. From there, each injured player was matched to an uninjured control in a 2-to-1 ratio, sorting by position, age, and minutes played. All players were sorted with someone that was within 2 years of their age. Performance metrics, including games played, minutes, and position-specific statistics like goals, assists, clean sheets, which is when a goalie does not give up a single goal in a match, were also compared. We looked at the year prior to injury, the year of injury, as well as the 3 years after to see progression of their play. Then we performed our statistical analysis using t-tests to determine the impact that these Achilles tendon ruptures had on return to play and the post-injury performance. So our results showed that there were clear position-specific effects in these players. Forwards returned to play, but ultimately their scoring ability dropped significantly, going down by almost half with a drop of 5.75 3 years after their injury, so it was not an immediate impact. Midfielders also had no significant differences in play in any category, which is of course important to know that you're going to be coming back at that level or have the ability to. However, defenders had an immediate decline in goals during the year of injury, which went down by 0.46, but later seasons showed no difference. Interestingly, goalkeepers actually showed an increase in clean sheets during the injury year, or their post-injury year compared to their controls by 0.37. So in conclusion, Achilles ruptures don't affect all players the same way. Forwards suffer long-term declines in their scoring, while defenders are affected right away and have a later recovery, while goalkeepers may actually see short-term gains. These findings underscore the importance of rehabilitation and return-to-play protocols that are tailored to the unique demands of each position in order to facilitate optimal recovery and sustained performance after injury. Thank you.
So Ann, stay up there. Now we're going to call up all of your colleagues. And we'll do 5 minutes of questions by the judges and then hopefully take a break.
My question's for Dr. Timmermann. Should professional goalkeepers undergo elective Achilles transection? Why or why not?
I would say absolutely not, as that finding actually only impacts their first year out in play, and then it is shown to be equivalent with their teammates and competitors in the future, that they have the same impact.
My question was for Dr. Arhewoh, and the caveat that I'm not a spine surgeon, But I was struck by, fundamentally my question centers around the power analysis and the fact that, this is a high-risk, low occurrence event. And that's what we struggle with entirety of anticoagulation. There's been studies looking at the fact that for total hips, to really put this question to rest, we need 30,000 hips in each arm. So while 3,000 is a large number, it may not be a large enough number. And how do you think that we could look at this better, perhaps with registries?
So I think we had done some, we had done some pre-power analysis where we found that 3,000 patients will be sufficiently powered to identify at least a 1.5% difference in risk, which is pretty high still for just how many of this happen. We were planning to do a post hoc power analysis to see if we felt like we were sufficiently powered, which we have not done yet. But pre-analysis, we thought that we were sufficiently powered. Still, I think that does depend on which study you believe on the baseline rates of DVTs and Ps after this surgery. If you believe there's some of the older studies that show rates as high as 1.5, 1%, then we are powered. If you believe studies that say that it's much, much less and it's 0.1, 0.2%, then I think we're just like the hip arthroplasty studies, then we're grossly underpowered. I think some of this is just a function of like, one, not having enough data to create great baseline rates. Two is that there might be a role for widespread registry data, but then you run into some of the same problems with like retrospective studies, with issues of different centers perhaps not imputing the same level of accuracy into the like database, and trying to figure out like again why some patients got anti-coag versus not. One of the I think strengths of our study was we had a very strict institution preferences towards not giving anti-coag or giving anti-coag. We had very similar patients population being treated by both groups of like surgeons, and we had like data extractors that were putting this data in from day 1 to 2 years afterwards. So we could really track things at a very minute level for all these complications that I think might be hard to recreate for a big, wide registry, but it's worth doing.
My question's for Dr. Nakken, and I will preface this as Dr. Mejia prefaced his with the fact that my retirement job is going to be cast tech. So how did you think about body weight or BMI as you looked at this, and how might that impact your results?
Yeah, so before we did this, I was hoping, for example, we have a 6'10", scrub tech, and I was like, oh, I need him for this study. And I didn't get him, but initially then in some literature review, actually low BMI is one of the risk factors for a pressure ulcer. And our 71-year-old with a BMI, lowest BMI, I think she was a BMI of 21, had very bony ankles and was indeed the highest initial pressure. So initially I did think, yes, we need obese patients, but it was actually ended up being the opposite, that the low BMI patient was our highest, and that aligned with some prior studies. So that's also something to think about, that even the little old ladies need that extra padding.
I think there were some really fantastic studies, so congrats to everybody. My question is for Dr. Plantz. I think there's a really, really good study that you did here, and I think, specifically looking at so many different outcome measures, I think that was really unique with this model. And so my question, I'm not, familiar with the rat model specifically with regards to how long fusion takes. Is 8 weeks enough to assess fusion in these rats? And that's one question. The second thing is that, your data is pretty convincing in this animal model. So if you could speak maybe a little bit towards to sort of the next steps here, are there any companies looking at bringing this to humans and what that looks like?
Yeah, absolutely, thank you. So to speak a little bit about the rat model, so one of the perks is that they do fuse pretty quickly. There's the model I think was first described back in like the early 2000s, and they followed it out for, in some cases, like 6 months or more, and the vast majority would fuse by 8 weeks, and that was for those autograft studies. So that's one of the perks of the models, that they'll fuse pretty quickly actually, and you can see like on micro CT, you'll see the bony ingrowth even at 8 weeks. One of the negatives is that most of them oftentimes they will fuse even with the sham surgery. So the fusion rate's about 40% if you just decorticate the transverse processes and don't put any graft in. Actually, it's around like 30%. So that's one of the limitations of the model, and why probably really the next step is the large animal model we use is New Zealand rabbits. So there's a much bigger space between their transverse processes, and they're more horizontal, kind of like in a human. So really the small animal model is just like a proof of concept to make sure you're getting osteogenesis, and then you use it to scale it up to a bigger model.
All right. I echo the comments. Great presentations from everybody. My question is for Dr. Maheshwer. So I've got a few kids. They're not quite as old as the adolescents in your study. They play sports. I'm worried if one of them gets an ACL rupture, I need to know how long to keep them off sport. So how do your findings sort of inform you in your counseling your patients?
Yeah, so a lot of the literature even now is kind of pointing towards this trend of trying to make these kids wait like 2 years after they have their surgery, which can be unrealistic in a high school age athlete, that high school is kind of the peak of their competitive play. So the way that we at our institution, our providers like to wait at least at the absolute minimum 9 to 10 months, but it also kind of depends on the age of the athlete and kind of the age that they had their initial injury. But we've been using this data really from a counseling perspective, I think just as our society's become more and more data driven, to kind of show them while they're very eager to return to sport when they feel okay, which for a lot of them is as early as 6 months, to really encourage them to wait those extra few months, because there is a cumulative effect in terms of their decreased risk down the road of sustaining another injury.
And just a quick follow-up, did you do any measurements on patients in terms of their strength or any sort of dynamic testing at all?
No, so that was not included in this study, but we're kind of in the process now of wanting to, because the physical therapy data was not very homogeneous to do analyses, we want to try to make that a subsequent study and standardize therapy protocols so then we can standardize strength testing and things that have more quantitative data.
Right on. Thank you.
Here to preserve your time for a break. So we will take a short break, be back. We'll do a little later, 2:45 instead of 2:43, so 2:45. How are you?
I'll take your sponsors if you want.
All right, so why don't we start with the final session? I just want to put at least one. This is like boarding gate here. Is Omar Martini? My understanding he is not here, but this is a final call. Okay. All right, so we're going to start then with the second in session 3, Conor Jones from Rush, who will give a presentation on repeat exposure to mesh glue dressing is associated with allergic contact dermatitis, a prospective cohort study.
All right, everyone, good afternoon. My name is Conor Jones. I'm one of the PGY5s at Rush, and I'll be presenting our study. This better? All right, don't start the time now. Okay, good afternoon, everyone. My name is Conor Jones. I'm one of the PGY5s at Rush. I'll be presenting our study, Repeat Exposure to Mesh Glue Dressing is Associated with Allergic Contact Dermatitis, a Prospective Cohort Study. Thank you once again for allowing us to present our work today. These are my co-authors. Without it, the study would not be possible. These are our disclosures, although none are relevant to the study itself. As background, wound issues following arthroplasty can introduce a host of untoward complications. They can make for a potentially challenging recovery for the patients, increase practice burden with increased follow-ups, and potentially necessitate a return to the operating room. As such, there are a number of dressing options on the market to mitigate wound complications. These range from semi-occlusive all the way up to negative pressure dressings. One popular dressing on the market is a polyester mesh glue dressing, which is a liquid adhesive. This
surgical dressing is semi-occlusive and thought to decrease incisional drainage, potentially decreasing surgical site infections as well as deep infections. However, there's a well-documented complication rate of allergic contact dermatitis. We'll refer to that as ACD following this dressing exposure. One large institutional study by Chalmers et al. Reviewed over 6,000 orthopedic patients and found this rate was about 0.5% with this dressing. In an iterative study at the same institution several years later of over 13,000 patients saw that number increase to 1.4%, up from 0.5. And so the question begets, is repeat exposure to this dressing potentially sensitizing patients and inducing some sort of type 4 hypersensitivity reaction? As such, the purpose of the study was to determine if repeat exposure to this specific polyester mesh glue dressing was associated with the increased risk of ACD following hip and knee arthroplasty procedures. This was a prospective cohort study where patients were enrolled prospectively from August of 2023 through May of the following year, undergoing primary total hip, knee, or partial knee replacements. They were excluded if they had an unknown dressing exposure from a prior surgery, had had a previous reaction to that dressing, or were healthcare workers as they may have been exposed during work. The methods were simple. Patients were screened preoperatively as having either had the dressing before, and if they were, then they were in the exposed group, or were never having the dressing before and were in the naive group. Patients in the exposed group all had documented operative reports demonstrating the use of this dressing. Demographics listed here were also collected. The primary outcome of this study was the development of ACD. Patients received an automated text message 7 days after their surgery asking if they had any itchiness, rash, blistering around the incision. If they replied yes, myself or one of the other study members called the patient to collect more information. All patients also received dedicated skin examinations at their first postoperative appointment 14 days postoperatively. Secondary outcomes were also collected listing here, and all ACDs were described using a mild, moderate, or severe collection, or criteria rather. These are our results. The patient demographics demonstrated no difference between the naive or the exposed cohorts. In total, we had 10 instances of ACD with 7 occurring in the exposed group. So 8.1% in the exposed group versus 1.9% in the naive group. So the exposed group had an increased rate of ACD. We then performed a multivariate logistic regression analysis, and we found that after controlling for patient demographics, a prior dressing exposure was associated with a 6.5 increased risk of ACD relative to the naive group. There is no difference in 90-day complications between the two groups. For our discussion, all reactions in the study were characterized as moderate and were all treated with topical corticosteroids as well as an oral antihistamine. The mechanism for this reaction is likely through a delayed type 4 hypersensitivity reaction. For those of you who don't remember from medical school, this is a CD4 innate mediated reaction where T cells are initially exposed to the antigen, and then upon repeat exposure, they are sensitized and induced a reaction. There are several limitations to this study. Although this is a prospective cohort study, this is a single center study and thus may have a limited generalizability. This is also underpowered for rare postoperative complications such as readmissions, reoperations, PJIs, and things of that nature. In conclusion, we found that in this prospective cohort study, prior dressing exposure increased the risk of ACD by over 6-fold when compared to naive patients undergoing arthroplasty procedures. As such, we recommend surgeons use measured caution with repeat use of this polyester mesh glue dressing. Thank you, everyone.
All right, thank you. We'll go ahead and invite Apurva Choubey from the University of Illinois at Chicago, who will give a presentation on joint arthroplasty and breast cancer, PE risk, and thromboprophylaxis. Depends on time since mastectomy.
All right. Good afternoon, everyone. My name is Apurva Choubey. I'm a second-year orthopedics resident at the University of Illinois in Chicago. First, like to thank the OREF and our wonderful hosts here at UChicago for getting us together. So my presentation's on joint arthroplasty in breast cancer patients, looking at VTE risk and how it depends on time since mastectomy. We have no relevant financial disclosures. So total hip and knee arthroplasties are amongst the most common and successful surgeries we do today. And for good reason. We can reduce pain and restore function. Due to this, there's a massive projected increase in arthroplasty surgeries. Just total knee arthroplasties are estimated to number up to 3 million by 2060. But it's also important to note that as the patient base ages, so too there are also increases in comorbidities and associated challenges. Now, specifically, we're looking at cancer, especially breast cancer. Now, this is especially apt as October is just around the corner as Breast Cancer Awareness Month, and we'll be seeing pink ribbons in our favorite athletes and pink cleats, but we still need to understand the reality of this devastating disease. For a woman in America, there's a 13% risk of developing breast cancer at some point in her life. That's 1 in 8 women. Now, and there's about 310,000 new cases of breast cancer each year. Thankfully, due to modern advances in medications like chemo, radiation, mastectomies, there's over 90% survival rate. But this is important for us as orthopedic surgeons because it's more and more likely that some of our patients in the future will be someone that has breast cancer or had breast cancer at some point. So we've previously had research that's looked at the impact of cancer in arthroplasty. We've asked if there are increased complications in breast cancer patients who undergo joint arthroplasty. We found that rates of pulmonary emboli are increased in total hip arthroplasty patients and total knee arthroplasty patients with breast cancer. So what we set out to find was what is the optimal time to do joint replacement in these patients with breast cancer so to best decrease the risk of venous thromboemboli. Now our methods, we use the Pearl Diver Mariner database. It's a large national claims data that includes more than 165 million patients going from 2010 to 2022. Our cohorts were patients older than 18 with a history of non-metastatic breast cancer who then underwent a primary hip or knee replacement. These were matched cohorts for age, BMI, comorbidities, and smoking. Our outcomes, we performed a multivariate regression analysis to evaluate the independent effect of time since mastectomy on rates of VTE on DVT and PE in these patients. So our results, we had about 17,410 total knee arthroplasty patients and 8,856 total hip arthroplasty patients. This is a 10-year post-mastectomy sample. Our data showed that there was a 30% decrease in DVTs and 83% decrease in PEs for patients undergoing total knee arthroplasty 5 years post-mastectomy compared to those who underwent total knee arthroplasty less than 5 years after their mastectomy. For total hips, similar picture, there was a 65% decrease in PE risk for patients undergoing total hip arthroplasty greater than 5 years post-mastectomy compared to less than 5 years. So overall, we found that the rates of VTE reached a nadir at about 5 years post-mastectomy. And this is amongst the first studies to provide a time-based marker for lowering VTE risk in arthroplasty patients after breast cancer. Thank you.
All right, thanks. Let's invite Jordan Serotte from the University of Chicago to present on AI-assisted MRI interpretation, improved surgeon performance in diagnosing Bankart lesions.
Thank you to OREF for inviting me here. My name is Jordan, and I'll be presenting my paper titled AI-Assisted MRI Interpretation, Improved Surgeon Performance in Diagnosing Bankart Lesions. Thank you to my co-authors listed below. So Bankart lesions are injuries to the anterior-inferior glenoid labral complex. Some studies state that they can occur in over 1/2 of anterior shoulder dislocations and can lead to pain, bone loss, and shoulder instability. Arthroscopy is the gold standard for diagnosing Bankart lesions, but there are other less invasive preoperative diagnosis methods such as MRI arthrograms or MRAs and standard MRIs. Standard MRIs are less invasive and have a lower cost, but they are less sensitive than the MRAs, which are greater than 70% sensitivity. However, MRAs are obviously a bit more invasive and expensive. So brief AI overview. So statistical machine learning is a type of artificial intelligence that uses manually curated variables like a person's age, sex, and BMI to predict some sort of an outcome. And then deep learning is a subset of this, which automatically learns the variables it's going to use to make the prediction. This has been used in other areas of medicine, such as diagnosing breast cancer or Alzheimer's disease based on imaging and deep learning, but has been largely unexplored in orthopedics due to the lack of public data sets. So our hypothesis was that deep learning models can detect Bankart lesions on MRIs or MRAs and help improve clinician diagnostic performance. We collected our own data set after receiving IRB approval of shoulder MRIs and MRAs from patients who underwent shoulder arthroscopy at our institution over a 9-year period, aged 12 to 60, and had preoperative ipsilateral imaging of the shoulder. We then had 2 shoulder and elbow fellowship-trained attendings and 2 residents review intraop arthroscopy images to determine if a Bankart lesion was present. Our exclusion criteria is listed here, but just they needed previous imaging and could not have had, they were excluded if they had poor imaging or if they had previous surgery on the ipsilateral shoulder. So we had 586 shoulders, MRAs and MRIs. The thing I wanted to point out here is that there were differences in our cohort demographics for the MRI and MRA groups, which reflect current clinical practice patterns. Typically, you're ordering MRAs for younger patients who you're worried about shoulder instability versus MRIs for potentially older patients with rotator cuff pathology. So we did have a higher percent of Bankart lesions in the MRA group versus the MRI group. It was about 30% versus 8%. Therefore, this is significant because we had to do separate models to do our Bankart lesion training so that our model would not just associate MRAs with Bankart lesions, and it actually learned what these look like. We did a multi-view ensemble, which just means that it took the 3 separate views from axial, sagittal, and coronal images to make one final MRA and MRI model. And then we used ROC curves to show how the model was learning. This is better for data sets with small number of true positives. And then since arthroscopy imaging was the ground truth, we compared our ground truth to how the radiologist did from their report on the preoperative imaging. We found that our model outperformed radiologists on standard MRIs and matched them on MRAs. We looked at accuracy, sensitivity, and specificity of the model, and then our model also aligned with the literature ranges for labral tear detection. So the clinicians, the 2 attendings and 2 residents were asked to read 117 scans twice, and once was initially, and again after a 60-day washout period with model predictions provided on the second try. Again, the accuracy, sensitivity, and specificity and confidence scores were compared. We found that the mean sensitivity improved from 40% to about 75% when clinicians were provided with the model predictions. The specificity remained stable around 90%, and the accuracy increased around 5%. And then finally, the diagnostic confidence increased significantly from 6.81 to 7.46. So in practice, we found a higher sensitivity and near stable specificity that improved the likelihood that preoperative imaging reflects the true presence of a tear when one existed. These results highlighted the potential for deep learning tools to supplement clinical interpretation and close the diagnostic gap between non-contrast and contrast-enhanced imaging and avoid the extra cost and patient discomfort and invasiveness of the MRA. We hope for future collaborations with other institutions to train and add additional data and conduct external validation. Thank you.
All right, thank you. If we can have Drew Carter from the University of Mississippi, particularly interested in this, as somebody who does this on call every now and again, but is intraoperative fluoroscopy necessary for spica cast application in pediatric femoral shaft fractures?
All right. Hey, y'all, back again. So, as I said before, I'm Drew Carter, fourth year at University of Mississippi Medical Center. And so this is the spica casting require fluoroscopy. At our hospital, we have a children's hospital that captures all patients from the state and surrounding states as well. We have a high volume of femur fractures. Here are the contributors to this project. I'm actually presenting on behalf of Dr. Chelsea Smith. I have no financial disclosures or conflicts of interest. So give a little background on pediatric femur fractures. They make up close to 2% of all pediatric fractures with a bimotor distribution, roughly a 2.6 to 1 male to female ratio. When the age is under 10 years old, it's most likely a fall, or most commonly, and greater than 10 is most commonly an MVC. The treatment algorithm for these fractures, as we know, 0 to 6 months is pelvic harness, 6 months to 5 years is typically non-op treatment, a spica cast, and then after that, it will go into operative fixation most likely, with flexible versus rigid nailing or submuscular plate and X-fix. Background study, Barnett et al. Had studied how often post-op radiography changed the management, and only 4% of those patients that were in that study required actually a change in management on follow-up imaging. So the aim of this study was to determine if there was a necessity to intraop fluoroscopy, and if that affected the coronal plane alignment of the femur fractures. And this was to determine if we could decrease the radiation load on this patient population if there was no necessity for intraop fluoro. So this paper was a retrospective study, and in the inclusion criteria accepted CPT codes of 27500 and 27502 for closed treatment of femoral shaft fractures, patients aged 0 to 5, open growth plates, non-operative treatment with spica casting, and a greater than 1 year follow-up. Patients that were excluded were those with pathologic fractures, or if there was a change in management due to a different treatment modality that was required. They accepted the coronal plane alignment of less than 15 degrees of angulation. And so here are the results. Out of 546 patient charts, 238 were eligible, with about twice as many being male to female. Average age was 2, and with the fluoroscopy, 87% roughly fluoroscopy was used in these patients, and 13% were not. Significantly noted, the operative time was less without the fluoroscopy rather than with, which is pretty common sense. Don't have to get the C-arm in, don't have to maneuver it and get extra shots and manipulate after that. So they found that based on the 3 follow-ups that they used, there was no influence of fluoroscopy on the coronal plane alignment up until the 3rd follow-up, which was the 1 year follow-up. And there was actually more angulation on that follow-up with fluoroscopy than without, which is opposite of what they were anticipating. Here, just an example imaging of spica casts with follow-ups as well. Their conclusion was that results suggest that the use of intraop fluoro has no statistically significant effect of coronal plane alignment of femur fractures treated via spica casting. Of note, of our attendings there, one does not use the intraop fluoro and the others do, and so I think one of the limitations is it is attending specific, but yeah, it's been shown to be just as effective without using fluoroscopy in our study.
All right, thank you. Yeah. So if we can have Ian Marigi close it out, and presenting from the University Hospitals Cleveland Medical Center, influence of GLP-1 receptor agonist use in tendinopathy, development in diabetic and non-diabetic patients, a propensity-matched database study.
All right, thank you for having me, and thank you for my co-authors for the opportunity to present. So I have no relevant disclosures. The disclosures of my staff are not pertinent to this discussion today. In introduction, tendinopathy is a prevalent condition accounting for over 30% of all musculoskeletal consultations. Relevant risk factors to discuss today include obesity as well as diabetes. The proposed mechanisms of this include an increased mechanical load as well as chronic inflammatory state. Approval of GLP-1, specifically semaglutide and liraglutide, for both weight loss and diabetes management can minimize the risk of tendinopathy in these populations. They have been shown to reduce systemic inflammation through improved glycemic control, marked weight loss, and suppressed production of pro-inflammatory cytokines. However, when studied in the context of tendinopathy, a study by Prado et al. Showed that GLP-1s can lead to accelerated muscle mass loss. This can alter the biomechanics load on tendons and potentially increase a patient's risk of tendinopathy. Overall, there is a paucity of data looking at the impact of these medications on rates of tendinopathy in obese and diabetic individuals. Therefore, the purpose of our study is to assess the impact of GLP-1s on the risk of tendinopathy in patients with obesity, diabetes, and both. Specifically, the primary outcomes compared include tendinopathy of the rotator cuff, biceps, patella, Achilles, and peroneal tendons between patients taking GLP-1s and non-GLP-1 cohorts. To achieve this, we conducted a retrospective multi-center review using the Trinetics platform. We stratified them into 6 groups: patients with or without GLP-1 use, patients BMI 30 as our definition of obesity, or less than 30, and then diagnosis of diabetes only in patients diagnosed with obesity. Our inclusion criteria included semaglutide and liraglutide use and ICD-9 codes diagnosis of diabetes and aforementioned tendinopathies. The exclusion criteria were less than 5 years of clinical follow-up, as well as patients less than 18 years old. Regarding matching, we had 43 million patients eligible for stratification. After matching, our cohort of obese diabetic patients was approximately 11,000 who were taking GLPs, and patients who were not was over 1 million, so we matched it to the same level. Regarding non-diabetic patients who are obese, there was about 4,000 taking GLP-1s who were matched to, and then diabetic patients with BMI less than 30, we found another 11,000 who were matched to. They were matched based on patient demographics as well as medical comorbidities. Looking at our demographics, our obese non-diabetic cohort was younger by approximately 7 years. The cohorts were majority female as well as identifying as white. The mean BMIs were similar in the obese cohorts, and the A1Cs were similar in both diabetic cohorts. The usage instances of GLPs were similar amongst all 3 groups. In our obese non-diabetic cohorts on GLP-1s, they had lower rates of biceps and Achilles tendinopathy, with similar rates of rotator cuff and peroneal tendinopathies. There was no patellar tendinopathies in this group. Diabetic non-obese patients on GLP-1s had lower rates of rotator cuff, biceps, patella, and Achilles tendinitis. And the rates of peroneal tendinopathy were similar. Looking at our diabetic obese population on GLP-1s, we saw lower rates of all tendons studied in this cohort. So in conclusion, our tendinopathy rates in patients with obesity prescribed GLP-1s were statistically decreased in Achilles and bicep tendons. In patients with diabetes, were decreased in rotator cuff, bicep, patella, and Achilles tendon. And then in patients with both, was decreased in all tendons evaluated, although the clinical significance of this did vary. Future studies could expand on additional GLP-1s that are now FDA approved, as well as study additional MSK pathologies associated with these tendinopathies. Thank you.
All right, thanks to all the speakers, all very nice. If you all want to come up, and we'll have you answer questions from the judges.
My question's for Dr. Choubey. Do you think we should tell all women who have had breast cancer, who need joint replacements, that they need to wait 5 years for an arthroplasty?
Great question. So, simple answer is no. So point of the study is also that it informs the surgeon that you also have options in terms of your anticoagulation. So if you're, say, just an aspirin-only user, now you can think about maybe doing something like Eliquis. You know, there's a recent study I just saw in the Bone and Joint Journal about the indirect economic effects of delaying arthroplasty. Now you're talking about all the additional medications, the additional appointments, just the indirect transportation costs. So no one's saying delay surgery for 5 years, but be aware that within the first 5 years, you're at an increased risk.
Dr. Carter, I'm coming for you again. As someone who would rather do anything than put on a spica cast, what, if you're not going to use fluoro, why go to the operating room?
I would say for patient comfort and ease of, honestly, the ease of putting on a spica cast. I haven't been, luckily, I haven't had to put on one in the ER, but I know in the past that was very routine. And I can't imagine having to go through that. One for the patient, having to be manipulated with a femur fracture present, as well as just for the surgeon themselves, having to try to manipulate and control it like that. So that would be my take on it. But as far as for the outcomes of the femur fracture, I can see where you're asking that, why you asked that. So, but if it was my kid, I would want him to go to OR and be asleep.
My question is for Dr. Serotte for the AI project. I think that's some really insightful work there, and I think moving forward, it's only going to get further expanded to other areas, and really a radiologist's worst nightmare probably. And so I'm a spine guy. I'm just wondering. So how did you actually? 'Cause it sounded like you actually trained the model, right? Or you sort of created this program with the deep learning and put in a lot of input there. If I was applying this, let's say to my field, let's say you wanted to look at whether a patient had an unstable spine, and often the MRI, you see some posterior ligamentous edema or whatnot, and then take them to the operating room, and then it's obviously stable or not stable. But let's say you apply to spine or other areas. So can you talk a little bit more about how you actually can train, how you do the training of that, the actual program before actually validating it?
Yeah. Yes. So a couple of steps that for time's sake I skipped through, but Stanford actually was the first database to do this, and they have a publicly available knee data set. So that was originally what we trained our shoulder one on, which just was basically reading an MRI, like what's a ligament, tendon, bone, what's pathology, edema, et cetera. And then we took it to our 500 MRAs and MRIs, and essentially 70% of those were actually still used to be trained. Randomized, but split between the MRAs and MRIs. And that's why when we did our clinician comparison, it was only tested on 117 of those. So obviously the more input that these models get, the better they get at detecting pathology and reading these, but that is part of the problem with orthopedics is just the lack of the initial data sets that these models have to train on. So our goal and hope is to make this publicly available so other institutions can use our shoulder MRI data set and continue to increase the accuracy of these models and apply them to different subspecialties within the field.
Ian, I had a question about your study. Did you look at so giving these medications to the patients that are obese and diabetic, decreased risk of tendinopathy, did you look at specifically whether or not that was tied to their weight loss or any other physiologic parameters?
So while we attempted to control one of the issues with, or one of the limitations of our database is we kind of get, separate snapshots of patients, and we can't follow, each patient specifically. So we were unable to assess, to what degree patients lost weight. We do know that the patients lost weight, but we can't necessarily assess if patients who lost weight reported less, rates of tendinopathy because we can't, match their specific, their specific clinical pathway to the outcomes. We kind of get two separate, but we get bunches of information that we can track, but we can't tie it as specifically as we would, hope to.
I think that leaves Conor. Your study was interesting, but I think that there's a lot of different factors going on when you're dealing with joints, and you're trying to juggle all this as well as efficiency. So you say judicious use. I just don't want to add something further in the decision tree. Would you just go to primary incisions, you're using it, and not use it ever in a revision? Or how would you simplify the judicious use of this type of dressing?
Yeah, I think it's, you guys can hear me. I think that it would be overstepping my boundary just to say, yeah, don't use it a second time. That's not my space to say. I'm not the surgeon. It's important to note that none of these are for revisions. These are all primary knees. It's just a contralateral, or primary joints. It's a contralateral knee. It's a contralateral hip. Things like that nature. I know that within our arthroplasty department, the providers who are in this study using this dressing no longer use the dressing. They use another dressing as a result of this study. So I think that all surgeons have to make their own decisions and have a conversation with the patient. The patient says, yeah, like I'm okay getting an allergic reaction, or I know that there's an increased risk, then it's a conversation, but I can't I can't broadly say what every surgeon should do based off this information.
All right. Thank you all very much. Very nice. We have time for about 5 minutes, so a quick break, and then we will go on to our invited speaker. Thank you.
Thanks, guys.
All right. Why don't we go ahead and get started with the kind of keynote lecture for this afternoon. And I cannot tell you how much of an honor it is to introduce Dr. Josh Jacobs. I don't think anybody in this room will probably meet anybody else in the rest of their life that has had as much of an impact on our field and the way it looks today. And I mean that without hyperbole. He is, now I did notice, originally from Chicago, went to Northwestern for undergrad, University of Illinois for medical school, left briefly to go to Boston, and then returned to Rush where he came back. But you have never come to the University of Chicago for any of your training. Is that general surgery was done where? That's close enough. So Loyola is the only major kind of training center in Chicago that you have yet to sort of tick off. But I have to say, I'm not going to go through the list of accomplishments that there's just no way to do it. But there are no organizations within our field that he has not been deeply involved with and for the most part led. So whether it's the president of the academy, he's been on the ABOS as a director, he's been the chair of Rush, one of the most notable orthopedic programs for 16 years, OREF, I can go on and on and on, and truly each of these sort of crisscross all the different kind of components that make up our field, whether it's the educational part, the research part, the clinical training, or even leadership. So it really, I cannot possibly do this justice. I think his impact in research in particular is obviously what we're really kind of focusing on today. And I think personally, he's just an inspiration of somebody who has always incorporated research as a key part of their clinical practice and what makes them and identifies them as kind of an orthopedic surgeon today. And I'm hoping that everybody has been sort of influenced by conferences like this, that, you know, research doesn't just happen. It's usually inspired by an idea. You have to sort of take the lead and to sort of follow it through. But it is so worthwhile doing. So I also wanted to just tell one thing, you know, that I think is particularly impressive about him. After 16 years of being a chair, I think you would deserve the right to just like retire and sort of watch things unfold without having to sort of continue being, you know, aggressively and actively involved. And your commitment to the field is really inspirational in the sense that although you are still, you know, actively being kind of, you know, a leader in our field. And I'm telling you, we deeply appreciate it. And I think he's going to share some of his own words of wisdom in leadership, particularly today. And I hope that you continue your involvement as much as you have in the past. It really is an inspiration to us all. So thank you.
Well, I really appreciate that incredibly gracious introduction. And it's really an honor for me to be here at the University of Chicago and to be the keynote speaker for the Resident Research Symposia. I just wanted to reassure our Rush residents, Conor and Jalen, don't worry, there's no electrochemistry in this talk, no metal ions, not the usual things I talk about at Rush. But I am going to talk about leadership, and the title is interesting, and I'll get into that. But never before, at least in my lifetime, have we seen such leadership challenges, what we're going through now. And so I think this is a very timely topic, number one, because of the society in general, but number two, because all of you in this room are either currently or will be leaders in one way or another, whether that's leading a department, leading a practice plan, a private practice, leading your family, leading a group in your organization. All of you are going to be leaders. And so it's important to understand a little bit about the scholarship involved in leadership and what leadership is and how we can all be better leaders in various aspects of our life. Here are my disclosures, and the only relevant one is I'm the current president of the OREF, which of course has been a privilege. I do want to acknowledge the Hark family who have supported this. William and Fred Hark were actually orthopedic surgeons at the University of Illinois, and they also worked at the time at Presbyterian St. Luke's Hospital. And somewhere around the late 60s, early 70s, Presbyterian St. Luke's Hospital reenacted the Rush Medical College charter, so they became Rush Presbyterian St. Luke's Medical Center. And the Hark family was amongst the William and Fred, the father and son, were amongst the early orthopedic surgeons during that transition. So the Hark family continues to support the REF. They support Rush. They support University of Illinois. And in fact, just today I talked to one of the Hark family. He was having an issue with one of his joints. But they're really wonderful friends of the OREF, and we're very grateful for their support. So I'm going to go through a few themes here. The first is, what are the attributes of leadership? I'll describe my personal odyssey. It's kind of a case study. The critical importance of mentorship, and another very critical factor that all of us are facing and will continue to face through our professional lifetimes, and that is, how do we balance all of this? The concept of servant leadership, and then a quote from one of my favorite thought leaders in this area, Joseph Campbell. And then a bit about orthopedic citizenship in its relation to OREF. So the title here is based on a book of Doris Kearns Goodwin called Leadership in Turbulent Times. Has anybody read that book? Okay, we have one. How about, they read the book that she had on Lincoln, Team of Rivals? Yeah, these are two phenomenal books, particularly the Team of Rivals, that I recommend to all of you about lessons in leadership. And in this book, that's right. That's right. She did. She wrote a baseball book. I actually got to meet her once at a Knee Society meeting. She lives in Boston, and one of my colleagues in the Knee Society was one of her neighbors. She's pretty down to earth. She worked for many years in the LBJ administration. And Lyndon Baines Johnson, for those of you that don't know who that is. But she really profiles 4 presidents and their personal odysseys toward leadership. And that is Abraham Lincoln, Teddy Roosevelt, Franklin Delano Roosevelt, and Lyndon Baines Johnson, who she knew the best. And there were some common themes that came through the writing and through her analysis of their leadership. The first thing, and I think it's a good place to start, is leadership is not innate. We are not born leaders. It's something that's developed. In fact, I never actually sought a leadership position when I started in this profession. It wasn't on my radar. I wanted to learn how to be a good joint replacement surgeon and do good research. And so leadership is something that tends to evolve in our lives. The other lessons from this are the importance of resiliency, overcoming challenges. And each of these 4 presidents had particular challenges in their life that really formed their personality and propelled them to do some really great things at some very difficult times. For Lincoln, he had many failures, political failures, business failures. He was also depressed, and yet he was able to be one of the most effective leaders in our history. For Teddy Roosevelt in 1884, his mother and his wife died on the same day. It's devastating to him. And yet he overcame that, and later in the 1900s became a very effective president. And for Franklin Delano Roosevelt, here's this wonderful, healthy, strapping guy who develops polio. This was an era before that we had polio vaccines, and how that impacted his life, and how that changed his personality, and how he was resilient to get over that. And finally, LBJ, who grew up in horrific rural poverty, had a chaotic domestic life, and how he overcame that to become effective leaders. And the common theme that runs through this book is the importance of resiliency, the importance of having a moral purpose. And in today's environment, we don't talk about that enough. We have a leadership model currently at the highest levels of our government that is not, you're not going to recognize that in what I'm going to say, in my comments to say. In fact, I've had to kind of rethink my concepts of leadership given the current leadership environment we live in, because the leader was chosen by, what, I don't know, 75 million people. And so I think we need to be open and honest about what we do and what we don't know about leadership. So this title is inspired by Doris Kearns Goodwin, and these common themes, I think, will be weaved throughout my comments. So here's a quote from Hesba Hoy, I think as the leader of Notre Dame. He said, "The very essence of leadership is that you have to have vision." And I would agree with this. This is very important. You have to know where you want to go. You know, and I don't know, you probably were too young to remember the George H.W. Bush, his presidential campaign. He was plagued by the fact that back in those days, it's kind of quaint when you look back on it. The main criticism of him, he didn't have vision. And he used to call it the vision thing. But it really is important in a leader. You have to know where you're going. Because if you don't, it's hard to lead there. And it's, according to Warren Bennis, leadership is the capacity to translate that vision into reality. In some ways, it's a simple process. The vision that you develop, which is formulated by your goals, your value, your culture, has to be enacted by a skill set to make it a reality. And this skill set includes decision-making, communication, negotiation, resource management. These are 4 of the most critical skill sets, and I'll go over each of them briefly. And then finally, the personal characteristics, not only the skill, but the personal characteristics, the emotional intelligence, etc., the power, the will, the discipline, and the desire, and all the other intangibles about an individual's personality that will ultimately get to the results. So it's simple in a way, but it's also very complex in all the elements that have to be integrated to make a successful leader. And obviously, the results then dictate, you know, a new vision, perhaps. And so it's an iterative process. So let's talk about the skill sets. The first is communication, and boy, is this a challenge. And I love this quote from George Bernard Shaw, the famous author and poet. The single biggest problem in communication is the illusion that it has taken place. I can't tell you how many times I've had a conversation with a faculty member, a student, a trainee, a fellow, a resident, a patient, and I was extremely clear in what I said, and, you know, you'd think I was speaking in some, you know, they just, it didn't go through. So I learned the hard way about this practice, what I call is active listening, active communication. And that is, you put something out there and you make sure that the person actually understands it by having them repeat it back to you. Kind of mirror what you said. I do that to my faculty if they come in or whatever, or trainee, and they will voice what's usually a complaint. People don't come to see me if they're happy. They see when they're not. And I repeat it to them. So what you're saying is Dr. So-and-so threw a dart in your face and now you have permanent visual damage. Do I get that right? You know, something like that. I just repeat to them what they said. And it's amazing how that helps in the process. They know they've been heard. You can probably think of situations in your life where you've communicated with someone and you didn't think they were actually hearing what you had to say. So this active communication, this mirroring, this feedback, I think is very effective. And then I want the person I'm interacting with to make sure they feed back to me, so what did you hear me tell you? Particularly when it's a difficult topic, so that at least you know that they're on the same page. I do that with patients too sometimes. So to make sure they understand the risks and the benefits of what I'm talking about, particularly if they're having a complication or it's a difficult problem. So another key part of the skill set is negotiations. And I'm not going to give you any of my secrets because one day I might be negotiating with you. As Rex said, I'm not going anywhere. So, but seriously, there are some keys to negotiation, and it's a very important part of leadership, and because we don't have infinite resources, you can't make everybody happy. You've got to say no sometimes, and so, you know, how do you get to a good place where, if not a win-win, people are not, you know, totally irate. And so the idea with the negotiation is when you go into it, you have to have a very clear idea of what you're negotiating. Sometimes if you're an effective leader, it's all been done beforehand in a way. And so you have to know, you can't, this is not something you can do on the fly. You have to know where you can go with the negotiation, what's your bottom floor, what's your goal. And I guess the best advice I have is to just be prepared in any negotiation. And whatever the outcome, make sure that you don't burn any bridges and it doesn't deteriorate into something that's very adverse and a conflicting interaction. Now, resource management, of course, is very important for a leader, certainly in this day and age. It's even more critical. And there's a variety of components to this. For someone who, for example, might be a department chairman, recruitment and selection, remuneration, administration. I'm not going to read all of these aspects of resource management, but it is a skill that if you're blind to what you have to work with, what are the resources you have to work with, then you cannot be a good leader. You have to adjust your vision and your tactics, et cetera, accordingly based on the resources, both human capital and other resources that you have available to you. This is a great quote from Mark Twain, that about decision-making, he said, good decisions come with experience and experience from bad decisions. And of course, no one's going to make the right decision every time. But the ones that become leaders learn from all their decisions, both the good and the bad ones. What worked, what didn't work. And this is how you build experience and become a much more effective leader. Yeah, there you go. Now, there's different styles of leadership. There's the authoritarian and autocratic. There's the participative, which is democratic. And then there's the delegative, which is kind of laissez-faire. And then, of course, Michael Scott would say, would I rather be feared or loved? Well, easy, I want people to be afraid of how much they love me. Well, that's not germane, but how many of you in your leadership roles, and I'm sure some of you have already experienced this, would consider yourself an authoritarian? Okay, no one's fessing up to it, but I suspect there's a few out there. What about participative? Okay, small minority. How about delegative? No one's a laissez-faire. All right, I'll go again. Which is the optimal form? Should you be an autocrat? No takers. Should you be participative? Okay, how about delegative? Okay, so participative wins. I would argue you got to be all three at one time or another. You have to be flexible. There are some times where you just simply have to make a decision and you have to impose it. I'll give you a silly example. Flu shots. I was responsible as department chair to make sure everybody in the department got their flu shots. And, you know, I would start out collegially and nice and progressively get less collegial, still being nice, and then progressively get less nice. But I never got overtly horrible, but at some point you say, look, you do this or else. So that's a case where you have to be authoritarian. In general, I really recommend that you try to build consensus and be participative, because ultimately the people are going to follow you if they buy into what you're doing. And the way to get buy-in is to take in what's important to them and factor that into the decision you're making. So I think in many ways, in many situations, this is probably the best style leadership. On the other hand, there are situations where it's good to be laissez-faire, where you do delegate responsibility. That's the way people grow. You have to allow people that are working with you, perhaps if you're a chair, your vice chairs, your deputy chair, your section directors, to make their own decisions, and then, you know, and just, you know, help them in managing the outcome of the decisions. So I think all of these are important to get adequate leadership success. And then, of course, there's this formulation of the relationship between how concerned you are for people and how you're concerned for results. Ultimately, we'd all like to be in the upper right, where we have equal concern for people and concern for results. We have examples of leaders that are only concerned for the people, and then that becomes kind of a country club management. That's not an effective manager. Sometimes you do have to make difficult decisions and make people unhappy. Because the way I used to formulate it is, if everybody's happy in my department, I'm not doing a good job as a department chair. If everybody's really unhappy, I won't last very long, but I'm not doing a good job as a department chair. So everybody has to be a little bit unhappy. Or look at it more positively, everybody has to be moderately happy. Because you can't be all things to all people. I don't recommend the authority compliance management where there's just a total concern for results. You also have to have concern for people. And if you don't care about either, well, that's what we call impoverished management. Leadership is a potent combination of strategy and character. But if you must be without one, be without the strategy. Interesting. Norman Schwarzkopf, I know the older guys, and you guys know who he is. Any of the younger people know who Norman Schwarzkopf was? He was a general in the first Iraq War. A very impactful leader, and really was kind of a hero in that whole process. Leadership, the character is critical, and exemplifying integrity and fairness, setting clear goals, maintaining high expectations, these are really important qualities of a leader. To support and recognize performance, to inspire people, stir their emotions, make people look beyond self-interest. That's a tough one, but that's how you really get big things done. And inspire people to reach further, inspire them to perform at their best. I always used to say, and I managed a lot of incredibly talented people in the Department of Orthopedic Surgery at Rush, and they all had their strengths and weaknesses. I haven't met the perfect orthopedic surgeon yet. And the goal of a leader is to accentuate and bring out the positives and to figure out a way to mitigate and manage the negatives, because it exists in every people. And that's the idea behind effective leadership. It's also important that as a leader, you have emotional intelligence, particularly self-awareness. We are all not good at everything. I actually took a personality assessment at one point, and we actually gave it as on a volunteer basis to some of our trainees, our residents in particular. And it's interesting to see that there are certain types of personalities, and these assessments are very effective in identifying areas of your character that are very strong and other areas that there's opportunities for improvement. And it's important that you know that about yourself. You don't want to have blind spots, because I promise you, if they're blind, they may be blind to you, but they're not blind to the people who you're leading. And so know what your weaknesses are and work with them. Address them. And if, I'll give you an example. One of the things I probably like to do least as the chair was manage budgets. Now, I talked about how important it is to manage resources. They have to get managed, but I would delegate that and work closely with someone who really could help me manage the books. And so that was one of my weaknesses. And so know that about yourself, know where you need help, know where additional training or coaching might be effective for you. So what's been my personal odyssey? I had this little niche training. I had a degree in material science and engineering up at Northwestern. I knew I wanted to be a doctor, but I was really fascinated by metals and polymers and ceramics and how they work. Always thinking that, boy, wouldn't this be a cool thing to apply to medicine? And what better field than orthopedic surgery, where we're putting in metals, polymers, and ceramics all day, whether you're a joint replacement surgeon, a foot and ankle surgeon, a spine surgeon. And so I was able to leverage that niche training into kind of a place that put me in a good position to make a contribution. My career really changed when I got this call out of nowhere. I was giving a talk at some meeting in the early 90s. I think I was out of fellowship maybe a year or two. And it was a talk on corrosion of implants or wear of polyethylene, something like that, something in my wheelhouse from being a material scientist. And it was from a guy named Bernie Mori, who many of you, hopefully you know who he is. He's former president of the Academy. He's also widely considered one of the fathers of elbow surgery. He wrote definitive textbooks on elbow, was also an adult reconstructive orthopedic surgeon, chairman at Mayo for many years. So he was the second VP of the Academy. He says, Josh, well, how would you like to be on the bioengineering committee of the Academy? Well, I didn't know what the Academy was at the time. I didn't know what the bioengineering committee did. But here's Bernie Mori calling me out of nowhere. So I said yes. Of course I said yes. And so the lesson I learned from that is be very careful at the early stages of your career about saying no. There are times to say no when if it's obviously illegal or unethical or what have you. But I mean, in general, when an opportunity presents itself early on, take advantage of it. You never know where it's going to lead. At some point in your career, there'll be times you can say no when you're established. I haven't figured out when that time is going to be for me yet, but at some times, most people do. And when you see an opportunity, don't let it go by the wayside. So I got on the bioengineering committee. I loved it. And the interesting thing was it kind of was in the same pathway as the research I was doing on materials and my interest in materials, my clinical practice, which was joint replacements, dealing with outcomes of materials we put in. And so this was all kind of on the same pathway, and it paved the way for organizational involvement in the Academy. I wound up on the Research Council after being in the Bioengineering Committee, and then on the board of the Academy, and eventually became the Academy president. I didn't set out to do that, but as the opportunities presented themselves, and by working hard and understanding the mission of the organization, it eventually allowed me to assume a leadership position. And then following that, leadership in the institution at Rush, as was mentioned. And all these things kind of worked together because there was an integration and crossover all the activities. So they were not separate. They were all about orthopedics and joint replacement and implants and my research in the biocompatibility of orthopedic implants. So it's a way to be a little more efficient with your time allocation. I mentioned mentorship. Well, this is a critical part of certainly of my story and probably most of the people in this room that have been successful. Choose your mentors wisely because they really can impact the direction your career goes. I encourage you to get multiple mentors. My big mentor in my life was probably George Galante, who was my fellowship director and really set the standard for me of the scientific basis of orthopedic surgery practice. But he wasn't my only mentor. Like every other human on the planet, George had some blind spots and some weaknesses. And so there are other mentors I have in my life, Gunnar Anderson, Aaron Rosenberg, but also mentors outside of medicine. My brother, you know, things like this. So you get different things from different mentors, different qualities. Make sure that it's a two-way street. If it's going to be a successful relationship with a mentor, that the mentee also has to bring something to the table. And I find that in my current mentor-mentee relationships, I also get a lot out of it. I learn a lot. I learn about current trends, current thinking. It keeps me young. It keeps me active. And those are my most effective mentor-mentee relationships. What about balance? How do you do that? How do you become a leader in an organization, in your department, what have you, and strike the balance between your health, your family, your community, your clinical obligations, your teaching obligations, research, and the list goes on. What I would say is, first and foremost, and the reason it's at the top of the list, is your personal health. You can't do any of the rest if you're not healthy, both physically and mentally. So take care of yourself. Number two, the second most important, is make sure you're there and present for your family. They will support you or not support you, depending on how you show up. And if you have the family support, you can do all these things in leadership and wonderful things. And then how you balance clinical teaching and research will be dependent on your particular interests and the particular bliss that you want to follow that I'll get into. It's a recommendation that I have to just be intentional about what your personal goals and desires are. As a matter of fact, even writing it down, making a list. What are your goals for your family life, for your personal life, for your community, for your specialty, for your academic life? What are these goals? Because if you set them out and you're intentional about them, you're much more likely to achieve them. And they may change. That's okay, based on experience, but at least be intentional about it. And for those of you that are going into academics, and you know, this is a pathway that I think is particularly valuable. I also believe that if you're in private practice and doing good work and taking care of patients, that's extremely valuable as well. But if you are going to go down an academic pathway, you have to understand what you have to do to raise amongst the ranks, your professorships, understand what's involved in an early time, what you need to do, figure out how you can get to be most efficient in your clinical duties with managing your time and getting the appropriate assistance, how you can get protected research time, what's the availability of startup funding. In fact, as you choose a place that you might want to work, you have to try to have these established up front. And as you go through your life, particularly if you want to follow the clinician scientist pathway, which I think is particularly valuable, then there's specific considerations, and that will depend on whether you want to be a collaborator with the scientist, whether you want to be a co-PI on certain grants, or whether you actually want to be an independent researcher. And those are slightly different pathways, and they have different commitments. I chose the one on the right because it's been particularly fulfilling for me, but there's been some very impactful and very successful orthopedic surgeons, and many of them are in this room, who have also made tremendous contributions by being very active clinicians and also investigators on grants. And all of that is possible. You might have seen this slide earlier from Lee Grossman, but I wanted to repeat it, showing how effective the OREF is in getting residents, helping them to boost their academic career. Individuals who got an OREF grant, a research grant as a resident, many of them they were much more likely to have a successful academic career. That's really our sweet spot at OREF. It's nurturing the young investigator, both young faculty and resident. And that's one of the reasons why we think it's so important that all of us as a profession, as an institutional citizen, we really do need to support the OREF. Final couple of concepts. One is this concept of servant leadership. And this is an old book by Robert Greenleaf entitled Servant Leadership, A Journey into the Nature of Legitimate Power and Greatness. And this is the mantra that I used and inspired me in my style of leadership. And that is, effectively, I am the servant of those that are following. My role, my success is based on the success of the people that I'm following. Not whether I get more grants or papers or more titles, what have you, but whether the people that I'm leading are doing well. And that is a way to empower those people around you, to make them buy into what you're doing, to inspire them. And I think it's a very effective model of leadership. And then I mentioned this guy, Joseph Campbell. Anybody ever heard of him? Okay, we got one. He's and two. Okay, an anthropologist at college in New York, Sarah Lawrence College. And he wrote some very influential books, Hero of a Thousand Faces. He was a cultural anthropologist who came up with this observation that very early societies that evolved separate from one another, like separated by oceans, where there was no way that there could have been diffusion of knowledge, these cultures developed in somewhat of a common way. And there were certain consistencies among them. So that's something he described. And in the process helped to form what was called the men's mythopoetic movement. And he had this wonderful quote in one of his books, and it's about how he himself became a leader in his field. He said, if you follow your bliss, you put yourself on a kind of track that has been there all the while waiting for you, and the life that you ought to be living is the one that you are living. Follow your bliss, and don't be afraid, and doors will open where you didn't know they were going to be. Ultimately, you're going to be successful and effective if you're doing something you love and you really like to do. And I really love what I do. I really love doing joint replacements and doing research in this area, and being an OREF president. I really love it, and that just really helps to propel me, gets me out of bed in the morning, gives me an extra step. So if you have a passion for something, follow it. Follow your bliss there. So some final points. Orthopedic leaders work very hard. That goes without saying. They're focused. They have a sense of purpose. They have a vision. They're creative. They do a great deal of planning. They are collaborative, and they love what they do. They follow their bliss. So if you want to read about this, I refer you to over 200,000 books on Amazon. This topic of leadership is very personal, and it's very prevalent. And it's also very important in our lives, in our professional lives and also in our personal lives. With that, I want to thank the OREF, the University of Chicago, for this great honor. Thank you very much. Questions, comments, rebuttals?
Yeah, we've got maybe 10 or 15 minutes. And I'm going to start with one question, because you sort of define leadership, and all of these are principles that are pretty well established, but it's interesting how definitions of what a leader is, how they're developed, what they do to be successful changes with each generation. And we've got a lot of new people from a new generation here. And I'm curious, what have you learned from young people about what leadership looks like today as opposed to what inspired you when you started?
Oh, what a great question. And boy, it's going to be tough for me to answer that. But I have learned a lot. And first of all, the world has changed. My God, has it changed. I remember in 1984, I was working in a research lab at MIT. And I was typing a paper. And I was using this thing called a word processor. And I said, my God, I can just hit a backspace and correct my errors. I didn't have to use whiteout. This is how, rudimentary it was back in the 80s. And now, here I have something in my hand that is just, it's got more computing power than anything that was available up until the mid-2000s. And at the tip of my fingers, I can have access to all the world knowledge. So these sorts of transformations have really changed everything. And it's only the rate of change is only more rapid with the advent of artificial intelligence and ChatGPT, the so-called generative AI. So first and foremost, I'm learning how to integrate these new technologies from you all, how to be more efficient, how to use them, how to try to use them responsibly. I think we're all grappling with that. The meeting I just came from, incidentally, was a meeting down on the 5th floor. We, at Rush, we have a grant with the University of Chicago. It's called a Clinical and Translational Science Award. It's a huge grant. It's 6 institutions in Chicago. And we're grappling with these issues of what's AI going to do to how we do research? What's AI going to do to how we educate our trainees, whether it's undergraduates, graduates, those in graduate medical education programs? Everything is being changed. So I need the mentorship of younger people who are what we call digital natives. I'm a digital immigrant, right? I'm learning this thing on the fly. You guys are born into this. You had word processors, you had phones from the moment you were sentient, and so it's just part of you and how you operate. And for me, it's not a natural thing. So I think the younger generation really can be very important in educating the older and how the new technology platforms can allow them to do things more efficiently and effectively.
All right, some questions.
How would you
Anybody?
answer that, Rex? Can I ask you?
I was going to say, for me, it was more the technology, because I'm unfortunately in the same era where I just did not. The way I'm communicating, and I'm not even on the social media, so learning how that has become the preferred method of actually communicating, and how do you take these principles and import them and adapt them to social media. I don't know enough about social media, so that's something that I learn on a constant basis. So I agree. I think the principles are the same, but it's the manner of communication. How do you kind of create the same spirit of leadership, oftentimes over a Zoom meeting? That's where the baton is going to be passed to everybody here, because that's a fait accompli at this point, and it's something that's evolving. And as I said, AI, I'm not even going to get into. That's pretty darn scary.
That's a really good point. I want to expand on that, and that's this whole idea of attention. I didn't have as many distractions as I was coming up. Now, I'm always seems to be double or triple tasking, particularly on these virtual meetings on Zoom call. You're on Zoom call, you see people's faces, but you can see that their eyes are on a keyboard, or they're doing.
And you're successfully doing that, because I can try it, but I'm looking away from the screen, and I had to say, Tessa, you can look at the screen and be sending off a chat in the background, and then there's like a phone. I mean, I don't know how I can't do it.
Necessity is the mother of invention. So I've actually been on multiple Zoom calls at once, one on my phone. And, it's an art. These are things, I had to be on both of these meetings. I just literally had to be there. I couldn't resolve the conflict. And, I don't recommend it to anybody, but the point, that's a levity point, but the point is that in this era, boy, how do you get people's attention? How do you get them to focus on something? It's getting harder and harder. And, we talk about that a lot in our ITM, and, how do we educate our trainees to learn what they need to learn to be effective researchers? How do you get people to pay attention? The world has changed, and I think we all have to adapt to it, and to be an effective leader, we have to understand these changes.
I think the solution are avatars, right? You're going to have multiple, it's going to be AI-generated versions of yourself. They take notes, and they report back to you. It's going to
or
be
clones. We can, cloning.
Same. It takes a little longer to get clones, but all right. Anybody, please. This is an amazing opportunity to talk to somebody who, again, has truly, made this field what it is today. But please.
Thank you for that talk. Knowing what you know now and all of the things that you've done, can you think of a time in your career where there was a fork in the road where you might have chosen differently? And why?
I think of the quote from the famous Yogi Berra. Everybody know who Yogi Berra is? Catcher for the New York Yankees. He had these great quotes. He used to say, when you come to a fork in the road, you take it. And although that makes absolutely no sense, there's actually some wisdom in that. I remember that question came to, I think was it Kamala Harris? Or no, it was someone. It was one of the politicians, and they couldn't answer. They couldn't fumble it. There have been a number of decisions I've made in my life that I've probably learned from. I remember there was one situation where I was a new member of the Academy Board, and I prioritized a board meeting because I thought it was just so damn important over a family event. And my mother-in-law, to this day, she's 93, has never forgiven me for not showing up at her bat mitzvah when she had it when she was 60. So I get grief from that from my mother-in-law, from my brothers-in-law, from my wife. So as I look back, there were times when perhaps I could have been a little more attentive to balance with family, and you know, it's always a struggle. It's always a struggle on when you're making decisions, you know, what are your priorities and how do you make that balance? And there's probably some other examples like that. In terms of, you know, professional decisions, I've been fortunate that the decisions I've made have worked out. But there is a kind of a principle in here. You make a decision based on the best data you have. This is true for leaders. It's all of us are going to face decisions where we don't have complete data. We face that every day in the operating room. We don't know exactly how, you know, this is going to come out, and there's some, you know, a little difference in the anatomy. You don't know exactly, but you have to make the decisions on the fly. So you make the decision, and then the issue is not whether it was the right or wrong, looking retrospect. It's how do you make that decision work, and what do you learn from it for the next time? So again, as Mark Twain said, you know, the art of decision making, being a good decision maker, is to learn from the bad decisions you made in the past. That's another question here.
Yeah, one question that we had is just kind of with all of the new changes, especially post-COVID, like more Zoom calls, as we were talking about, or other online opportunities, how do you think like your leadership stance has changed, and how do you continue to be a good leader in all the different roles that you are in, especially with all of these changes to current learning for residents?
Yeah, it's another challenge, another interesting question. I think, like anything else, you know, these new platforms are here to stay, and it doesn't do me any good to lament that they're here and miss the old days, and we're missing something when we don't have face-to-face meetings. The question is, how can you use it most effectively? I mean, it's a discussion that I have frequently with Lee Grossman when we plan our OREF board meetings. We really see the value of face-to-face meetings. There really is a value in that interaction. But there are certain transactions that we can have where we get more input when we have it virtual. So I think we're still learning on how we optimize all these platforms, and I think this is here to stay. In many ways, though, it has increased the reach that a leader will have available to them, that they can be present at meetings and not be there physically, and they don't lose the time associated with travel. I was a keynote speaker in the Korean Orthopaedic Association during COVID. And instead of it being a one-week ordeal, flying, the jet lag, I did it, dressed very professionally up top, not so much below the Zoom camera, and I did it from the comfort of my home, and it was a 1.5-hour investment in time as opposed to, 7 days of difficult travel. Now, I lost out a lot on the personal interactions I would have with the Korean Orthopaedic Association, but I was able to participate and do other things. So it's these changes are here to stay. The question is, how do we leverage them and adapt them to make it the most effective for us in our leadership activities?
All right, any other questions? I have one quickly, which is very different and maybe a bit more pragmatic. So we heard a little bit about sort of the challenges, particularly what's confronting the NIH and a lot of things that are happening as far as research support. And I'm curious, from just the vantage point of musculoskeletal research, you have a knowledge of so many different perspectives on this issue, and OREF is obviously one part of our solution, without a doubt. But I guess, can you give us kind of your thoughts? How much of this is a crisis?
Yeah.
You probably know this better than anybody, and I think it's important now, and I think this is going to affect all the people in this room in terms of opportunities for research, potentially career development, et cetera.
Really, really critical issue, and it's something that has been a focus of a lot of us in research leadership positions. How are we going to weather this storm, what I call the federal research funding cliff? First of all, so far, knock on wood, I don't see, oh, here we go. Some of the draconian cuts are off. They've been put at bay. One of the worst was the cut of the NIH indirect funds from the mid-50s to 15%. Does everybody understand what NIH indirect funds are? Okay, so this is important that you understand this because you're citizens and you have to understand that some of the rhetoric you hear about this is so off. So the way the NIH funds research, and by the way, the NIH is an absolute gem. It's an absolute global gem. And I think the US probably funds research more per capita than any country on the planet. And it's one of the reasons that we're leaders in medical research, biotechnology, orthopedic devices, in so many different areas. So our NIH is absolutely a gem. And investigators from all over the world want to come to the US because of their ability to have the freedom to do research here and have the resources to do research. The way NIH grants work is, and they're the most desirable grants for two reasons. Number one, they pay the highest sum of money, these federal grants, and number two, they cover the indirect costs. The direct costs are the salaries of the personnel that are doing the studies, including the faculty salaries, a portion of their effort that's being dedicated to the project, any research assistants, reagents, new equipment that you might want to buy. So it does cover the direct costs of the research you're doing. What it doesn't cover is the indirect costs. And what are they? Well, that's the electricity that, so you can go into a lab that has light, the water, the immense research regulatory apparatus, the IRBs, the regulatory committees, the compliance officers that have to make sure that research is done, particularly human subject research, in an ethical way. And there's a tremendous amount of research regulations. And so those indirect funds, those are negotiated with individual institutions based on their facilities costs, their overhead, and it's very carefully negotiated over years. I think Russia's is 57%, UChicago's similar, and so for every dollar of NIH money that you get for direct costs, you get 57 cents to cover the indirect costs. And by the way, that doesn't cover the full cost of research. Way back when, the Institute of Medicine came out with a study showing for every NIH dollar that you get, direct and indirect, the institution should be investing about 50 to 75 cents. That's just to have modern buildings and to provide what you do. So even with the indirects, they're not paying for the full cost of research. By cutting the indirect costs from 55% to 15%, it's devastating. Institutions, they can't cover that. For some institutions that have big NIH portfolios, it's tens of millions of dollars. And where's that money going to come from? So what it means is less research, less researchers, a brain drain, people leaving institutions, leaving the country, and ultimately a decrease in our innovative output. So it's just silly and it's dangerous. So that was the biggest threat. That's now tied up in legal status. There's a court injunction that's preventing the implementation of that cut, and we hope that that never happens, but that remains to be seen. In addition, the White House proposed a 40% reduction in the NIH budget, which is an absolute disaster for the same reasons. Fortunately, the latest version of the House bill was, I think, a 10% reduction. The Senate was a flat or maybe a slight increase. So luckily, there's broad bipartisan support in our legislature for NIH research. And we hope that continues and they're not browbeaten by the executive branch into doing something that they know is not in the best interests of our country. Not only for medical research, but also for commerce and our trade balance, et cetera, et cetera. So these are amongst the biggest threats. I was with Alfonso, we were up on Capitol Hill, was that yesterday or 2 days ago? Anyway, we were up on Capitol Hill National Orthopedic Leadership Conference, and we had 4 issues that we were advocating for. 3 of them were more pocketbook issues for orthopedic surgeons, but the 4th was actually medical research. The peer-reviewed orthopedic research program in the Department of Defense, which was totally cut out of the budget. It's $30 million a year, which doesn't sound like much. And for the DoD budget, that's a rounding error. But for us, $30 million a year funds a lot of research. And they cut out entirely, they cut the budget 57%. In the process, they cut out entire programs, but they left intact things like breast cancer, prostate cancer, melanoma, important diseases, but they're not all necessarily that relevant to battlefield injuries, to the active military. And there's an institute called the National Cancer Institute that has $7.5 billion of funding. So we were trying to talk some sense into the policymakers to hopefully get some rationality into this. we're living in a very fraught time where in some sectors of the HHS, there's an anti-science bent. And I'm holding my breath. I just can't wait till it's over. I just hope the amount of damage that's done is contained and that we can recover from it. We're all waiting and trying to make sure that we can do our part in mitigating this. But right now, it's a fraught time.
Well, again, thank you for all that you have done to help on this front, and we do appreciate your time here today, all the wisdom you've imparted on us. So thank you, thank you, thank you.
Thank you very much for your attention.
So do we want a quick break or do we want to go straight? Okay.
And the winners are?
Yes. Okay. All right, so without further ado, well, first of all, I want to thank the OREF for supporting this and everybody. I remember when I was a resident, and I guess it must have been one of the first regional conferences, because this was in like 2000 and maybe 2, 1, somewhere in there. But it made a huge impact on me. So I wanted to thank you for all that you've done. So there are going to be 3 third-place awards, and you said $500 each. Okay. And in no particular order, the first is Apurva Choubey. And if you can just stay up long enough to get a picture, please. Congrats. Yeah, we'll get all 3 in the okay, the next is William Day, University of Mississippi. Wait.
That's not correct, I'm sorry.
Oh gosh, that is a. Oh, I did not, that are marked. I'm sorry, I thought they were in order. Oh my gosh, I may owe you $500. I'm telling you, that is really, oh. Okay. So wait, let me, okay. Sorry, and I'm serious. I'm gonna make up for this. Yes, I'm gonna, I'm really embarrassed. All right, so next is Kyleen Jan from Rush. All right, and the last 3rd place is Mark Plantz from Northwestern. All right, so do we want to have all the 3rd places? We'll come and take some pictures. All right, congratulations to you all. All right, and there are 2 second places. These are each awarded $750. The first one is Bhargavi Maheshwer. Congratulations. All right, and the second and final second place winner is Erik Nakken from the University of Michigan. All right, congratulations. All right. Our first place winner is Katherine Montoya from the University of Arkansas. Congratulations. And this is $1,000. We can give you some recommendations for restaurants that would maybe cover one person, so. All right, congratulations. That's a huge, huge honor. And can you reiterate, so for the first place and the 2 second place are eligible for the national symposium? Okay. And that will be announced after all of the sessions are done, they're just going to group them all together and give them an invitation. Okay, all right. Okay, now, the presenter's choice, and is this, can you tell me a little bit about what goes into this particular award? Is this just one that this is from? Got it, okay. So the presenter's choice goes to Jordan Serotte. $600. Woo! Open it. Open up your certificate. All right. So again, I really want to thank everybody here for, as said, number one, just being involved in research first and foremost. I know there are a lot of people from your institutions that also submitted abstracts. They were all literally, I have to say, they're all worthy of presentation. We don't have enough time to do it. But again, we thank you for at least, moving the field forward through research, which is the key theme of the OREF. And
in order to get your checks, you need to see Carmen, who is in the back of the room. So everyone who got a certificate, see her in order to get the actual money.
Okay. And then the last thing, I just wanted to thank all, like Carmen, I've known you for ages. And, Deborah, I'm sorry, I was like, thank you so much for helping to set this up and make it such a special event. So I hope you all, it's Friday. Yeah, don't forget, well, she's by the door. You can't leave if you have as said, she will get you taken care of. All right, but thank you all. Enjoy the weekend, and until next year, and I don't even know which institution it's going to be at next year, but
For the Midwest, it's
Wisconsin. All right. Till next year. All right, you guys, have a nice weekend. Thank you.
Nice to see you too. You're not very far from home.
No.
That's good.